Yep, there he is. Right, Dr. Wentz, if you'll sit there at the head of the table. Testing, 1, 2, 3. You got it, man.
Okay, I knew I could do this.
A 1, a 2, a 1, 2, 3, and. Maybe go as soon as you are. Hey, welcome back to the Sports Medicine broadcast. This is, again, Dr. Josh Yellen for the University of Houston Master of Athletic Training Program. I have with me today Dr. James Muntz. Dr. Muntz, thank you very much for joining us.
Testing, 1, 2. That's all I know about radio.
Yeah, that's right. Across from me is your host and founder, Jeremy Action Jackson. Jeremy, how are you doing today?
Doing great. It's good to have you back.
Yeah, thanks. Dr. Muntz, I want to ask you a few questions. We know that obviously you're here from Memorial Hermann, the Ironman Sports Medicine Institute, and we're collaborating with UT physicians. And I want to ask you a little bit about you, your background, your bio, and how you got to where you are.
Okay, I'm originally from Tyler, Texas. Went to Indiana University for undergrad training. Went to Baylor here in Houston for medical school and residency. And as far as sports affiliations, I started out with Houston Gamblers, Houston Oilers for 10 years.
Who are the Houston Gamblers?
Old school USFL football team with Jim Kelly was their quarterback.
Oh yeah, I saw an NFL show about that.
And Houston Oilers, Gamblers, indoor football, outdoor arena. I've done Dynamo for a couple years. I've done the team doc for the Houston Rockets for 20 years. I've been the doctor for the baseball Astros for about 12 years. So my wife, I told her I have an hour and a half off a year where the's not a game going on.
Yeah, that's right.
She said that's too much time off. I'm wasting my time.
And so tell us a little bit of background. You know, the other day, yesterday, we had Dr. Bajani sitting in the seat, and you and Dr. Bajani are both going to serve as co-medical directors for our new Master of Athletic Training program. So thank you very much. And so tell us the difference of your training so people that are listening can understand the difference. Dr. Bajani is family medicine. He did a family medicine residency, and he did a sports medicine fellowship, and you're internal medicine. Is that correct? So tell us a little bit about the differences between the two and how that applies to your knowledge and what you do with the athletes.
In a nutshell, what Dr. Bajani does is family practice different from internal medicine. They take care of youth, youngsters, elementary school on up. As an internal medicine doctor, we don't usually take care of people until they're 15 or 16 years of age. He's a sports-trained guy. I'm an internist who I would describe myself as I take care of medical problems for sports people and athletes.
And so let me ask you just a couple of differences from the internal medicine side. You know, you said that you take care of adults that happen to engage in physical activity or, you know, athletic performance. What are some of the main issues that you're seeing today in the sports medicine field? Because you've said, obviously, you've been around for decades. How has that changed? What other things have you learned from the time that you came out of your residency training?
Probably the most common things that we see people for are daily injuries, overuse injuries, soft tissue things. Anybody that has a significant orthopedic injury, shoulder dislocation, bad knee injury that we can't take care of, we work along with the orthopedic surgeons with that. Whole lot of attention to concussions now that I didn't see stuff with 20 years ago with this kind of deal. A lot of attentions to minor illnesses, the flu, mono, sore throats, pharyngitis, headaches, migraines, asthma that could affect somebody during school, during their performance or whatever, and we, you know, probably that's most often what we see.
So I want to go back a little bit. You know, we've talked to a number of different physicians and other medical professionals, and it seems like there are a number of different ways that somebody can get in the sports medicine field, right? Obviously, you can be an athletic trainer, you can be a PT, you can be a strength coach, but really from the physician side, it sounds like you can be an orthopedist and go into sports medicine training, or you can be family practice, internal medicine, pediatrics, physical medicine, and rehabilitation, and there's a lot of overlap, it sounds like, between the professionals. So for instance, one of the things that you said is 15 and 16 up. And so 15, 16 can also see a pediatrician, correct?
That's correct.
And so what would be the difference between an internal medicine physician seeing a pediatric patient and a pediatrician seeing a pediatric patient? The only reason why I'm asking is that you have a lot of people that are listening to the show that may just be getting into the field, and or they've just graduated as athletic trainers and they're trying to assemble their medical team, and so they're trying to figure out the differences.
The biggest thing that a 15 and 16-year-old kid will come see me for is they're your size, and they said, I'm not going to sit in those baby chairs or get in the train in my pediatrician's office anymore. So they want to leave and get a big man doctor because they don't want to go to the pediatrician anymore. So that, there's a comfortable transition with that. Huge crossover between this stuff. The sports guys like Bojani and them are great because they do, all the medical care for elementary school, middle school, so forth, and would obviously pass something on that was an orthopedic issue, critical surgery, that kind of thing. I guess at my level, and I've seen with some of the other NFL team physicians, NBA docs, we're internal medicine, and I think we have a fairly sophisticated training program that's good for adult level, cardiac stuff, respiratory asthma, blood issues, things like that. And we have pretty intensive, comprehensive training. Bojani's guys and people that are sports trained are very comfortable being the team docs for these middle school, high school, college, and certainly pro teams. That more and more sports trained guys are doing sports. And the NFL, as of now, when I eventually stop, every doc, I think the NFL has to do family medicine or internal medicine and have a subspecialty in sports.
They have to be fellowship trained in sports.
Yes, correct.
So going back to NBA, so let me get this straight. You've been with the NBA, or you are with the NBA, the NFL, and Major League Baseball. Can you expand a little bit about some of the major changes that you've seen over the last 10, 20 years in the care of these athletes, but more importantly, your interaction with the athletic trainers?
Tough question. Just more attention to detail. Athletes, interaction, better nutrition, better exercise programs, on down to something that people may not pay a lot of attention to. Their record keeping, pill keeping, pill ingestion, supplements, anti-inflammatories, the records, the detail, side effects, complications, explaining this to the athlete's parents, to the agents. I mean, it's gotten more and more expanded in that nature. I think people are very aware of information, internet, things that they can come up with. So I think our job's gotten bigger and bigger and bigger and taking more and more time with more attention to detail.
And so I'm sorry, Jeremy, do you have a question?
No.
Oh, no, okay. So can you talk a little bit about, as a team physician for some of these pro sports, and I'll kind of give you a scenario, right? You're the team physician for one of the pro sports, and I'm the head athletic trainer for one of these pro sports. Can you talk about the interaction? Because, yesterday morning we also talked to Dr. Lowe, and he sat in this seat. And so it sounds like, right, for all those that are listening and trying to figure this out and building these various sports medicine teams, we have a team orthopedist, and that's Dr. Lowe. And then we have a team physician, right? So we have a team surgeon, team physician. So tell me a little bit more about your interaction with those head athletic trainers that maybe Dr. Lowe wouldn't have a conversation with, and vice versa.
I guess in my experience, the the trainers are the guys or the ladies that are on the scene when there's an injury, illness, and they're in charge of directing where the player goes. Somebody obviously tears up their knee, and I'm the co-doctor with Dr. Lowe. That goes to Walt, goes to Dr. Lowe. Somebody's got fever, illness, cough, chest pain when they're working out, dehydrated. Usually that's directed to me more than the orthopedic surgeon, or to Bojani or whoever your sports person is.
Right. So it's really talking about, okay, we're going to take, yes, you're all physicians, and some are orthopedically trained as surgeons, and some are trained as physicians in non-orthopedic injury. Can you talk a little bit about big term that's been going around for a while now is the non-surgical treatment of orthopedic injuries? And so all of us in the field know what that means, but there are some people that are listening that don't quite understand. What's non-surgical treatment of orthopedic injuries?
Probably, and again, to summarize quickly, not spend a bunch of time, would be to pick the knee. Somebody hears a pop, tear, can't walk, that's going to the orthopedic surgeon. Mm-hmm. A runner, marathon runner, long distance, middle distance runner has knee pain, they can still run and so forth. You're certainly not thinking going in a surgical approach with that. I'd say that's a non-surgical issue, knee pain. Dr. Lowe would be very happy for the medical person to look at that before they came to him.
Right, because it's a non-surgical.
Achilles tendon, they've got heel pain, running, heel spur, not going to surgery. The medical guys are very good at dealing with that and addressing.
And in your opinion, over the last, say 10, 20 years of dealing with this, somebody's just coming out of school. Let's say they're coming out of, athletic training school, and they're just embarking on their career in sports medicine, and you were to give them some advice, like some of my graduate students are going to be rotating with you, and you're going to give them some advice of how to, what's it going to take to be successful in this particular profession? What are some of the nuggets? What are some of the pearls that you can pass down?
Obviously, you wouldn't get through this program if you weren't smart and adept at what you do. Probably the biggest things that are important for success are being available, friendly, good communication skills, and first and foremost, the athlete's your patient. So you protect them against themselves, against the trainers, against the coaches, from putting somebody back in that you don't think is ready to play. So I think that kind of summarizes it up.
Well, I know that you've got to go give a lecture, so we really thank you very much for your time.
I've got to say one thing in conclusion. Yes, testing, sir. 1, 2, 3.
All right. Thank you very much. Again, this is Dr. Josh Yellen for the Sports Medicine Broadcast. And again, Dr. Muntz is serving as our co-medical director for the program. And you can get the program at www.hhp.uh.edu/MAT. And you're also now working with UT Physicians, isn't that right?
That's correct.
And so we've been fortunate enough to be able to affiliate with UT Physicians, and so our students can be rotating with you. Good luck on your lecture. Thank you very much for having us. I'm Dr. Josh Yellen for Jeremy Jackson, the entire Sports Medicine Broadcast, and Dr. Jim Muntz. Thank you, sir.
Thanks very much. UT gets a copy of that testing 1, 2, 3. I might lose my job.
Don't worry.
I've got the perfect.
This goes out to just a few dozen.
I've got the perfect face for radio anyway. Nice job.
Doesn't have to deal with this basketball coach anymore.
Why got fired?
No, you got him a new job. That's why I wanted this CPR stuff. Let me talk to Randy about it. I'm not going to go back to work just for that.
Howdy. Hi, are you Dr. Yellen?
I am.
I'm Webb Moran.
Hey,
How are you, sir?
how are you, man?
Nice to meet you finally.
Great, yeah.
I apologize about the
You're not
delays.
anything that I thought you looked like.
It's been, it's hard to get things in a timely manner when you have to run it up the flag and back.
I understand.
I haven't forgotten about you. I'm glad I got a chance to meet you today.
Yeah, and the reason why I sent the NASA thing is that I was hoping that, Continental or, TSA, wherever it was, would,
It's not a problem. TSA won't be a problem. Is it when I escort you, I have the badging to be able to take
yeah, I
care
was
of
hoping
you.
to say like, all right, I've already gone through federal security clearance. So hopefully it's-
That won't be a problem. The more of the issue is just that they are so concerned about the rest of this.
I understand.
So
What are you doing right now?
I'm just about to walk in the meeting. I got time right now.
You want to be interviewed? You're going to miss the meeting.
Interviewed regarding.
This is something called the Sports Medicine Podcast.
Okay.
It's a podcast for athletic trainers. Sure, the brainchild of two athletic trainers from Pasadena High School. And Mark Allock and I got involved because there's a way that we could promote athletic training and talk about the Master Athletic Training Program, stuff like that. And I think that you would be a really unique set because, here you go, here's an athletic training in the industrial sector doing for Continental Air. And so you can talk a little bit about your background, your training. I mean, it's going to take you missing this talk. But,
Sure.
yeah, awesome. This is Webb Miranda.
Yep.
You guys know each other?
We chatted for a second.
Well, I mean, I've seen him at conferences through the years and kind of.
Yeah, Webb's an athletic trainer with Continental Airlines. So he's on the industrial side, similar to what I do over at NASA. Good Dan Barnes?
Yep, that's
Oh, yeah.
what I told him to
Oh, yeah,
send him
yeah,
in here
yeah,
to talk to
that's
you.
How do you know LSU?
That's where I graduated.
So Jack, Shelley, Andy, Sean, they're all here.
Oh, really?
Yeah. Where are you from?
I graduated in 98.
Did you know Jeff Schmidt?
Oh, one of my best buddies in the world, absolutely. Him and his wife Annie, we were all athletic, we were all student trainers together.
So I was at Southeastern Louisiana University before I came. And Jeff runs North Sports Medicine. So Jeff was one of our preceptors, so I did outreach for Jeff at University.
You know Robbie Belchet?
Sure I do.
Was my cousin.
Rob Peltier is your cousin.
Yep.
Rob Peltier taught my general medical class.
Small world.
Wow.
He's my mother's brother. They
How
were
about-
from home in Louisiana.
How about that? Yeah, Schmitty was, here's the story. I show up in Los Angeles, and I did outreach for Los Angeles Unified School District. Similar to what these guys are doing for all of Houston. But it was me and, essentially a bunch of graduate assistant athletic trainers. We didn't have the setup that these guys have. And I was working for one of my mentors, Dr. Jared Bornstein, who's an orthopedic surgeon. We covered all of LAUSD. And, we'd go to Compton and Crenshaw, here's a white Jewish guy walking in like, okay guys, here's how it's going to go. And so I take the job at Southeastern after graduate school for a number of different reasons. I moved my wife to 7 Catholic Purgatory on her service. I moved from sunny Southern California to Hammond, America. And we lived in Ponchatoula for a little bit, then we moved to Baton Rouge in a community. And so first day, I must have been in Louisiana for a week. Schmidt finds out where I live. He comes by, gets out of the time he was driving like UW jet or something like that. He says, "You yelling?" I said, "Yeah." He throws me a North Oak shirt. He says, "Here's how you get to Eaton High School." I said, "What am I doing?" He says, "We'll take care of everything else later. Go." Okay, and I was with him for 10 years. And so we brought North Oak Sports Medicine into our athletic training in Southeastern. So, I mean, it was a great.
Yeah, one can sit right there.
Have this conversation.
Yeah, it can be exclusive live content.
Yeah, it was
Start
outstanding.
recording whenever.
So let's
you're
get
ready.
you, Webb, sit right here.
Didn't know what you were getting into when you said you want to come in here and meet.
Well, what a small world.
That's funny. I know. Yeah, Schmitty and I were student trainers together at LSU.
Well, that's why.
Me, him, and Annie. That was, in fact, we traveled football for 2
Ray
years
Castle
together.
must have been there.
Yep.
Ray's now the program director.
Yep.
Well,
I don't suppose, did you ever meet Jim Minch?
I know who he is. We've come across each other.
Yeah.
Jim.
He was my graduate assistant. He's the one that taught me into going to Temple for graduate school.
Really?
Yeah.
Well, let's turn this thing on and start talking. All right, so you got to talk right into the microphone here.
I got you.
Hey, welcome back. This is Dr. Josh Yellen for the Sports Medicine broadcast, representing the Master of Athletic Training program at the University of Houston. Find us at www.hhp.uh.edu/MAT. To my right is Webb Miranda. Webb, thank you very much for having us.
Thank you for letting me be here today.
We were just talking off air that we found out that we have some similarities. So some of the similarities that you and I have, and I've always talked, the athletic training, you hear like Kevin Bacon's 7 degrees of separation, and I think that athletic training has the same. So we were just talking, I saw that you're wearing an LSU Tigers athletic medicine Nike jacket.
Yeah.
And I asked, how do you know about LSU? And you said,
well, this is this is an original. I got this when I was 1992 when I was traveling with the football team, and it's still in pristine condition.
Still is in pristine condition. And so you graduated from LSU in what year?
1994.
And so I asked, Jack Marucci, Andrew Barker, Sean Eddy, and Shelley Mullinex? And you said,
absolutely.
And then I said, you must know, if you came out that year, you must know Jeff Schmidt. And you said,
not only did I know, Jeff and I were student trainers together at LSU, and his wife Annie, we were all trainers together.
And for those that don't know Jeff Schmidt is now the director of sports medicine and the head athletic trainer at North Oaks Hospital, based out of Hammond, Louisiana. And Jeff was a preceptor for me, and North Oaks was a clinical site for me when I was, so my little history is that I came 2004 as faculty, and then I became clinical coordinator in 7, and then I became clinical coordinator and program director from 2010 to 13. And along that entire time, somewhere along the line, I was, I guess, smart enough or dumb enough to get my doctorate. And then I always worked outreach for Jeff, and so we did North Oaks physicals. We did, all sorts of great things. And so we'd always take pictures, and we're going to end up taking a picture too. And I'd send it into the NATA News and say, look at what we're doing, look at what we're doing.
Well, if Jeff, you're listening to this, you'll appreciate the story. When he first started out there, and Amy, he was born and raised in outside of New Orleans in Terrytown, so very much a city boy. And he first went out to Hammond, and he was visiting one of the schools, and he was checking out a young man's hand, and he said, well, he was given his restrictions for practice, and he says, well, can I still milk a cow?
Yeah, that's right.
And Jeff's like, I don't know. How do you milk a cow? So he had to have someone explain it to him, and so they sit there, they diagram, and they went over, you can milk a cow. But he didn't know what to tell him.
I understand. I'm from the big city in Los Angeles, so I came from Los Angeles. My wife is from Newport Beach. And so I had the similar experience, and I think that's the reason why Jeff always laughed at me, because he knew that he went through it. Now, Annie is from a small town, his wife, Annie.
The metropolis of Bunkie, Louisiana.
And when the first time that Jeff told me that Annie was from Bunkie, I said, there's no way, because there's no town called Bunkie, Louisiana. And sure enough, I was on my way to a conference somewhere, I think for the LATA, and I came across Bunkie, Louisiana, and I text messaged Jeff and said, you're right. Yep. And then one time the only thing I knew about Louisiana before I moved out there is a song by Jerry Reed called Amos Moses. Have you ever heard of that song?
I can't say I have.
And Amos Moses was an alligator hunter 45 minutes southeast of Thibodaux, Louisiana. That's how the song goes. And one day I was on my way down to Nicholls State University in Thibodaux, Louisiana, and I came across an alligator in one of the waterways. So I stopped and I took a picture and I said, hey, this is just like Amos Moses. So
Nicholls State, I believe they call themselves Harvard on the Bayou.
Yeah, that's right. So, Webb, tell us a little bit about, obviously your first name is not Webb, correct?
Vincent is my first name.
And how'd you get Webb?
Webb is my middle name.
Okay, so Vincent Webb Miranda.
Jr.
All right, so that means that your dad's name is Vincent Webb Miranda.
Senior.
Yeah.
Hence the whole voice change thing. They wanted to avoid those kind of problems. When somebody asked for Big Vince or Little Vince, they just started calling me by my middle name.
I totally understand. Now, going back real quick, your cousin is Rob Peltier. And Rob Peltier is the chief medical officer for North Oaks Hospital. And Rob taught a general medical class for me when I was program director at Southeastern Louisiana University. So small world, right? So we talk about the athletic trainer's circle of influence, and it turns out that you and I don't know each other, but if I go 1 degree out, we know a bunch of people, right?
We actually go way back without even going way back.
That's exactly right. So tell us a little bit about you, right? You got your bachelor's. Now we already know you got your bachelor's from LSU in what year?
94.
And then you went on, you got your master's degree.
Well, I attended Temple University's master's program.
And then what years did you go there?
That had been 94 to 98.
And then after 98, you leave Philadelphia, and you come back to?
I go down to Houston, and I started working in high school down here in Alief ISD at Elsick High School.
And so going back, are you originally from Louisiana?
Baton Rouge.
Baton Rouge, Louisiana, where?
10-12 split, so basically...
Sherwood Forest?
Jefferson and Drusilla.
Oh, yeah. I know exactly where I lived right off of Sherwood Forest. Lived right off of Charrington, and my wife worked right off of Acadian Thruway.
There you go.
All right, so you leave Philadelphia and you come down to Alief High School, and you work as an athletic trainer there. How'd you get from Baton Rouge to Philadelphia down to Houston?
When I was after I was about to graduate, I wanted to maintain being an athletic trainer, so I wanted to go to a graduate program in it, and so it came down to between the University of Kentucky and Temple. Both of them had master's programs. Kentucky's got a beautiful facility, and it just seemed like either one of those two options was really good. And I thought, well, I've already been in the SEC. I know what it's like in the South. Let's do something a little different. Plus, at Kentucky, I'd have been working as a graduate assistant for university. In Philly, I'd be working at a high school. So it gave me a chance to do a different setting too. Okay. So I became the administrative assistant for the professor in charge of our program. At the time, it was Dr. Iris Kimura.
Okay.
And she was in charge of the graduate athletic training program at Temple. So I became her administrative assistant. I worked her office every morning, took care of some of her classes, and did some of her administrative work. And
so
then,
you're like a teaching associate,
right?
Essentially, yeah.
And then in the afternoons, I'd work at the high school, which was Springfield, Montgomery County, just outside of the city.
Okay.
Totally different environment than I was used to, and it was interesting going from a situation where I always knew I had a head athletic trainer and had other people around to being by yourself.
So let's talk about that experience for a little bit. Let's talk about going from a big Division I, Tier 1 university like LSU, where you've got everything you need and everybody's there to help, to go into a high school where really you don't have a whole lot and you've got to rely on yourself. So tell us a little bit about that transition.
That was probably two things: the growing experience of moving to Philly, totally different culture than South Louisiana, obviously. Forced me to grow up a lot in a very short period of time.
And how old were you at this time?
24.
Okay.
And then the other aspect of it was the fact that you had to actually rely on. It's no longer theoretical,
right,
what you learned in class, and you go through something and you'd have somebody verify that you were on the right track, or you need to think maybe you need to relook at it. Now you have to rely on what you learned to go ahead and look at these kids and be confident in what you did. And so it was a little
And tell us
nerve-wracking.
about there are so many people that when they're looking at, like for instance, as we all know, athletic training is going through an education transition again. There's a lot of talk about moving to an entry-level master's. The NATA Board of Directors, sent out a statement of 11 reasons. And so now we've started this master's degree in athletic training at UH. And so I've got these kids now that have all got degrees in kinesiology, exercise science, that kind of background. And now they're coming into a situation where, again, just like you and I came out of entry-level undergraduate athletic training programs, they're going into entry-level master's degree athletic training programs. But I've always said, when I came out of the undergraduate education, I didn't necessarily feel prepared to practice. I didn't feel like, I came out of, similar to you, as a KHEP accredited program, but I came out with like 3,500 hours, whatever it was. And then I got into practice, and I had to really work that trade. So expand a little bit more about, if you transition from a big Division I, Tier 1 university like that, similar to how I came out of, to a smaller high school, you can't rely on the MRI anymore. You can't rely on your team physicians, and it's you. You are the MRI. You are the X-ray. You are the team physician. You are the head athletic trainer. So talk a little bit more about what that's like.
Well, I think that the biggest issue that I had at first was almost overconfidence. I figured, well, I've been at a big school. I'll be able to figure all this out, and you get humbled very quickly when you feel like you know too much. You feel like you got it all figured out, and it really humbled me at first to start seeing these things and starting to realize that you need to take your time and you need to look at what's going on, and you need to rule things out as opposed to rule things in. And it was really difficult at first because equipment-wise, I went from a place that had any piece of equipment in the world that you wanted, and you could order anything at any time, to a budget of $5,000 a year.
And what can you get for $5,000 a year?
A couple boxes of tape.
And so you went from a situation where you have every modality, every diagnostic test to, do you have modalities at the high school?
I had a whirlpool that I could make either hot or cold.
Okay. But you didn't. They weren't separated.
No. It was either one of the two that day. I had a nice machine that was in the other part of campus, so I had to go get a nice chest every day. So if I wanted to have a cold whirlpool, that was 2 trips.
Right.
I had one ultrasound machine.
Okay.
One stim unit.
Okay. And it wasn't the combo units the way that, a lot of these students come out now and they're all these intellect combo units. It wasn't that way when we were coming through.
No, and both of these machines could have been the Smithsonian. They were so old.
And, it was the E-stim, the carbon impregnated, where you had to wet the pads and then,
Absolutely.
Yep. Okay. And, it wasn't necessarily calibrated to the right, right? And then ultrasound, their heads, the ultrasound heads were about as big as his microphones.
Yeah, and there was no, choosing which setting you wanted to go. It was just one. I had 2 tables and a golf cart. And it was a 1A school in like I said, in the suburbs of Philadelphia. Beautiful place, a lot of fields to cover, a lot of different sports. I had field hockey and lacrosse, and I'd never even heard of those things in South Louisiana, much less actually seen them live. So I got to work different sports and different things that I wasn't used to working.
So in that Philadelphia, you worked football, equipment intensive. You worked field hockey, equipment intensive. You worked lacrosse, equipment intensive. What other sports did you come across that you didn't necessarily get exposed to?
Well, most of the schools over there, like in Texas, but they didn't have this in Louisiana. They almost all had their own natatorium attached.
Okay.
So I started working with a lot of swimming.
And for people that aren't as smart as you, well, I had to learn what a natatorium is. What's a natatorium?
A really nice swimming pool.
Inside.
Inside.
It's inside.
Yes.
Yeah. Okay. So they had an indoor swimming pool.
Yeah.
Okay. What
and
else?
Diving. So,
diving.
Swimming and diving. Injuries from those that you've never dealt with much at from the high school level in Louisiana. Obviously, we had all that stuff at LSU, but we didn't have wrestling. They had wrestling there, and wrestling in Pennsylvania is huge.
Yeah, sure.
Huge, even in Eastern PA. Obviously, in Western PA, it's as big as football in the South.
Right.
But it was very intensive, and it was a lot of fun to work wrestling. I enjoyed that. It's a lot of work because kids start to bleed very easily, and there's always a lot of injury time. But it was a lot of fun. It's very very intense.
When I was in Louisiana, I got the opportunity to work AAU Junior Olympics with wrestling, and so I did some work for East Jefferson, and Jason Oakland and David Mocklin are down there, and so we did some AAU junior wrestling, and I got a real good education on what this wrestling was. And so now you're the only athletic trainer at this high school.
Yes.
And you're covering all of these sports. Tell us what that was like.
Having 4 walkie-talkies out at 4 different fields. At this, they were blessed with having a lot of space out at this high school. So they had a field that was really, really high on campus. They had a couple of fields that were low. So you have a lot of crossover sports, obviously, in high school. Different seasons cross over different times. One of the busiest times for athletic trainers is typically February and March,
right, when
you are finishing basketball and soccer, and you have track and field and baseball and softball going, and you're preparing for spring football. It's you think you get a breather after football season's over with, but you're actually, the craziness is just starting.
You mean for work, not necessarily in our minds.
Right.
Okay, go ahead.
And up there was the same kind of thing. You'd have a soccer game going and a lacrosse game going and basketball practice and softball and baseball, and trying to cover literally 5 different venues and 6 venues at the same time with giving walkie-talkies to coaches. The days could get a little bit hectic.
And so tell us about that conversation, right? You're the only athletic trainer at this high school. You're covering a couple hundred athletes all at the same time. You've got all these sports going on, some of which you've never seen until you got to Philadelphia. And you're going to have a conversation with the coach that says, "Coach, here's a walkie-talkie, and if anything happens, call me." And up until that point, maybe those coaches have never seen an athletic trainer before, so they're used to working on their own. Hey, suck it up or throw some dirt on it, or, pain is just weakness leaving the body. And so tell us a little bit about that transition and some of the things that you had to do to get buy-in from those coaches.
A lot of times you're right. It's like, well, we haven't had an athletic trainer here before, so I don't think we're going to need anything. But then they discover in a hurry that they don't necessarily want to take that responsibility. If it's something non-complicated, like, oh, we took care of it. I heard that a lot. Oh, we took care of that. And a lot of times you were scared to think of what that might mean. But they start to realize in a hurry that we're here to assist. We're not here to take away from.
We're not the bad news bears.
Right. We're not the bad guy. We're not trying to take anything away from you. We're trying to help you do the best you can and help the kids do the best they can.
So talk a little bit about that kind of proactive education where you're going to sit down with, now you're 24 years old. Mm-hmm. And I'm sure you heard just like I did, son, I've been doing this longer than you've been alive. And so, but now you're really the medical authority. And you've got to be able to sit down with these coaches and get them to buy into what you're doing. So talk a little bit about, because you've got some people that are going to be listening to the show that are coming out of similar situations, either undergraduate and post-professional education or entry-level masters, and they're going to go on and take on leadership positions the way you did. And so they're going to be able to learn something from you to say, okay, well, I listened to Webb on this broadcast, and okay,
you're in trouble.
Yeah, that's right. So tell us a little bit about how you did some proactive education with the coaches and administrators.
Well,
some things you did.
There were some of them that were really receptive right off the bat. They didn't want to have. They never liked the responsibility of being in charge of the medical for kids. So they were very receptive, and in fact, they came in for a lot of advice and a lot right off the bat. And so, just trying to work with somebody and let them know, educate them as to what we do. My job is not to just take a kid off the field automatically. We're here to help keep them on the field, but in the safest way possible. And if the best thing for you in the program is to take a kid out of play, then it's not because we're scared to let anything happen. It's the best thing for everybody involved. But I did have my football coach at that high school was old school guy.
Yep.
And had only had an athletic trainer one other time before, and he believed in practicing 4 or 5 times a day, and
100%,
every
and
all
if
full pads.
If we're not cracking femurs, we're just not doing what we need to do.
One of my favorite moments was at the end of the year. We were the day before our last game. He decided to have a full pad onside kick drill. Now, at this point in the year, the kids, they've already beaten each other pretty well. Why we were in full pads on the last day before the last game, I still couldn't tell you. But, of course, a young man gets a knee in the back, it cracks 2 ribs that pierce his kidneys.
Oh, boy.
And so, he's in a lot of discomfort. Bring him down to the training room, and kind of on a hunch, I said, let's go ahead and check your urine. And sure enough.
He's bleeding. And
so he's in the ER. In pretty bad condition, and they're worried about saving that kidney.
Yeah.
So kind of the last day, and so explained to him afterwards, like maybe in the future, it's really not going to be necessary to do a full contact drill on your last day of practice.
Yeah, my counterpart, Dr. Mark Knobloch, he's our clinical coordinator for our program. He was a head athletic trainer at Lamar University for 7 or 8 years. Then went back, got his PhD, and he came across Sandy Miller, who's over at Stephen F. Austin now. And there was a time where Mark tells the story of Sandy and he are talking, and he's really frustrated by one of the coaches, and Sandy sits him down and says, "They're not getting hurt in our practices." And so I agree with everything you're saying. It sounds like you and I follow we have the same education, right? Protect the patient. Yeah. Protect the patient, proactive education, try to control your situation. So you've got your own athletic training room there now, and you're doing rehab, you're doing taping, you're doing emergency medicine, you're doing all of it. And you've got this one little, how big do you think your facility was?
Oh, let's see. Take about 6 or 7 telephone booths, put them together, and that's about, it was a very small room.
That's about it.
So we had one for the spring and the fall, and we had one for the winter. You couldn't be out. There was nothing going on outside up in PA. It was all indoor sports, swimming and basketball. So in the wintertime, I had a little training room inside of the gym that was probably, a couple hundred square feet. That was it. It was very, very tiny. And then the one outside was probably 300 or 400 square feet. So same thing. It was both very tiny facilities. And you learn, it's one of the great things about being in those kind of settings is you learn how to make do, and you learn how to improvise. You learn how to find different space. You learn how to use other equipment. You don't need thousands of dollars worth of exercise equipment. You learn how to use the things that are available to you in the best way that you can. You know, a chair can be a great place to work out from if you use it correctly.
That's right.
A wall is a great place to work out from if you use it correctly. So you get very creative. And that was one of the, and I think that was one of the real benefits for me going to that setting was I learned how to use other things.
So it became very resourceful.
Absolutely.
Okay, so now we're going to fast forward again. You go to Houston, you're doing high school athletic training, and then another transition happens. Is that right? And it brings you to our current position now.
Yes.
Okay, and tell everybody what you're doing now.
Well, I am an athletic trainer for Take Care Health, and we have the contract for United Airlines. So I work at the hub here in Houston at Bush Airport.
And so you're in the industrial setting of athletic training.
Yes.
And two of the biggest areas in athletic training are industrial and physician extender. And so actually right over in the background here is Bruce Nischwitz, and Bruce is one of the athletic trainers I work with at NASA. So you guys have some very similar experiences. That Bruce also was a high school athletic trainer and transitioned into the industrial side. So expand a little bit about what you do now on the industrial side of athletic training as an athletic trainer, really for Take Care Health at Continental Airlines.
United.
United Airlines. Sorry, excuse me.
Well, I tell you what. When I first got there, it was interesting that when I was interviewed for the job, the gentleman that interviewed me was a athlete at Texas A&M. He was tight end, and his idea was whenever I was at a sporting event, we had an athletic trainer there. Why can't we have the same kind of thing at the airline? And if you think about it, there's a lot of different people that work a lot of different roles for any airline. You know, your pilots, flight attendants, gate agents, ramp agents, maintenance. A lot of different people, caterers. So you have a ton of people that come together to get that plane moving and getting where it needs to go. But specifically, let's go with a ramp agent. How are they different than any other athlete? They lift, push, and pull hundreds and hundreds of pounds of baggage, mail, and freight on per flight, much less over the course of an 8-hour day. So it's not that they're athletes, it's just for an 8-hour shift, not for a 3-hour game. Right.
So they're what we call, at NASA we use the term, and I didn't invent this term, but they're really an occupational athlete.
Yeah.
Right. They have repetitive injuries, they have overuse injuries, and they need to be conditioned to do certain things. They need to be taught proper ergonomics. And so now that we look at the new practice domains of athletic training, we went from 6 down to 5. And the first one is that, injury prevention and health and well-being. So it sounds like, do you do a lot of that at work?
I think that's primarily what I try and do. The best I can, I use my background as education to educate the employees that are there, hopefully, the best that I can into how to help prevent having a problem. It's one thing to go ahead and take care of it after it's occurred, and we have mechanisms in place with workman's comp to be able to take care of somebody. How do we hopefully avoid that situation? So working on the educational aspect of it, working on the ergonomics, working on the musculature, showing the importance for core strength. All those things come together to hopefully help them prevent them from having a problem. Because if they get hurt, it's not only does it affect the company, but at the end of the day, it affects them as an individual.
Right. So there's really loss of revenue.
Right. It's their bottom line.
Right. It's their bottom line. And so I came across a great article that I've shared with a few other people that in the occupational setting, for every dollar invested in an athletic trainer, it's a $7 return on investment. So there you are, and you're preventing injuries, and you're preventing them from happening. And it sounds like your athletic training education has really come into play there. That one of the things that separates us from other healthcare professionals is that prevention, right? Okay, so tell us a little bit more about what are some other things that you do on a daily basis?
Well, I'll do a lot of educational stuff. I'll have briefings where we talk about specific items that they're dealing with. Now that I've been there long enough to know the specifics of how the area works. It's not just theoretical anymore of this is how I would lift something. Now I've been around long enough to where I can go out, show somebody, go to their work area with the baggage or with whatever the item they might be working with, and show them a way, hopefully, that's a little bit easier on their body. Follow up with people that have been injured. So like doing a lot of preventative work, and then people that have been hurt, go back and visit them in their work areas and hopefully work on something that can put them in a less risky situation in the future. And
tell us about the facilities that you have there at Take Care Health. So if somebody does get hurt, can they go to like an athletic training room and see you?
That, or better yet, 90% of my time is spent outside of the clinic. So
is that right?
I go to visit them in their work areas.
That's outstanding.
So I spend most of my time either upstairs in the concourse working with the people that are up there, or down on the ramp with the ramp agents down there.
And you're the first athletic trainer there?
Yes.
And are you the only athletic trainer there?
Mm-hmm.
So now you have a major Fortune 500 company, this huge airline that now understands the value of an athletic trainer. And have you been able to show a decrease in injury?
After I've got there, the powers that be have been able to take the numbers and show the value over to United. In fact, United did open they had clinics in the traditional continental hubs, so in Houston, Newark, and Cleveland. So when we came together and we merged into United, they opened a clinic up in Chicago. So now we have an athletic trainer that's up there too. So
So you were the first in the country.
I don't know if I was the first in the country. I was definitely the first for them.
At United.
I don't know. I believe Delta did have some that worked in their hub in Atlanta.
But as far as United Airlines, you were the first.
First one.
Okay, so you really were the trailblazer.
Yeah.
And then they're following. They're going to try to find another web.
Yeah, they have one. He's outstanding. Great guy. He's an athletic trainer in the Chicago area.
And so I would assume that if I were to kind of be a forward thinker, I would see that there's probably going to be some other openings. Now, if somebody wants to get into the industrial occupational setting and athletic training, how do they do it? Obviously, with you,
mine was if I went looking for it, I'd never found it.
Right.
It came to me.
Mm-hmm.
That's a good question. It really is. I think one of the places that you can start is these outreach programs that many, like Memorial Hermann's a great example.
Mm-hmm.
They approach people, and they are approached on a regular basis for ideas into those type of settings. So my particular company, Take Care, same kind of thing. They're approached with these ideas, and then they look at different settings that this might be appropriate. So I'm sure they've already taken our model and presented it to other people that might be interested in having that in their companies in the future. I really think that as fields go, you're going to see more and more athletic trainers in industrial settings because it just blends. It
makes sense, right?
It does. It really
makes
does.
Sense. I had a similar circumstance. I was in graduate school. It was along the same lines, and we were bidding out whether they were going to go with a PT or a chiropractor or an athletic trainer. And I listened to the PT and the chiropractor, and I got up there. I was in graduate school, and I just got up there, and I asked the chairman at the time, I said, "Sir, I noticed that he was from the Midwest based on his accent. It turns out that he was from Chicago, and he's a big Chicago Bulls fan. And so I asked him, if we're qualified to rehab Michael Jordan and get him back to work, how come we're not qualified to rehab you and get you back to work?" And you know what? And the contract went to the athletic training group based on, the athletic trainer has the ability to prevent the injury. When it happens, is trained on the immediate care, but can also do the rehab and the reconditioning, and then create an entire program to make sure that this never happens again. And that's everything that a good athletic trainer is going to do on a daily basis. And now we're just doing it in the industrial side.
And that's the other advantage of being out about in the environment is it's hard for me to tell somebody something to do if I'm not aware of what their situation is.
Right.
We're on the sideline for an event. We watch what's going on in the game.
Right.
We see them at practice every single day. We know exactly what they're doing. Well, it's the same kind of thing in that setting. If you get an opportunity to see what they're doing in the work area that they're in, it makes a lot more sense for you to be able to go over and say, okay, I understand. This is the position that you're in. What do we do to modify that? This is what you're doing every single day. How do we strengthen a set of muscles that you use on a regular basis so that you can be less sore, something of that nature?
So really from an athletic training education side, which is really kind of my world, my objective is to be able to speak to people like you and say, okay, how do I train these students to be more versed, not just in a specific setting in athletic training as it was when you and I were coming out, but athletic training as it expands across all these other broad-based, whether it's industrial, physician, extender, it's really about exposure and making sure that they've got the experience. So when they take on a job like this, that they've seen this before.
And you know, that's the key of the solid foundation, the having the knowledge and the background. You know, it doesn't matter if you're flinging a weight, or if you're flinging a bag, or if you're pushing a cart, or if you're pushing whatever it happens to be. Athleticism is athleticism. The key is having the base to know your background, knowing your ergonomics, knowing how to do those things, and then you can tailor it to the different areas that you're in. So as an athletic trainer working in high school, I might approach things a little bit differently, but I have the basic knowledge that I can walk in the basic knowledge to be able to talk about somebody how to lift a bag as well as lift a weight up off the ground.
One last question here before we break. From my own education, right? If you were to speak to, if you had the ability to design your own athletic training education program, based on where athletic training is going now, where it was, where it is now, where it's going in the future, what's one thing that you think you would add to make the athletic training more valuable in all of these fields?
Oh, wow, that's an excellent question. Just thinking of my background, most of what I did, we did just a ton of on-the-job training, and that was excellent. And we had a good background from the schoolwork that we did, but for me personally, I would have liked to have had a little bit more intensive of the educational aspect of it, because we had plenty of time in the classroom. I don't think that's an issue anymore from that perspective. I think nowadays, I think for the sake of the newbies that are coming out now, is more exposure to different settings.
Right.
Like what you're doing now.
Yeah, not just, hey, you're going to have 1,400 hours in football.
Right.
It's, you're going to have all these different looks, all these different settings. So when you get out, you are prepared to deal with, every avenue of athletic training.
You have to get out of your comfort zone.
Yeah.
For your own sake, even if you don't like it, you don't appreciate it at the time, but later down the line, you're going to look back and say, I'm so glad I saw those many different things.
Right. Well, I want to thank you very much, Webb, for joining us and taking the time. It turns out that you and I have a lot of very similar pathways, right? That we know the same people, we've been in the same areas, and like we talked about before, Kevin Bacon's 7 degrees or 6 degrees of separation. Athletic training, I think, only has 2 or 3. And that you and I don't know each other, but if we went 1 degree out, we know a bunch of people that we commonly, know, including Jeff and Annie Schmidt and Rob Peltier and Shelley, Jack, Ray, Andy, Sean over there at LSU. I think they run a great program over there.
I'm ashamed of myself for not remembering, but who was the head athletic trainer at Southeastern before?
Well, it was Bob Goodwin.
Okay.
And then Bob retired. Yeah, and then it retired, and then it retired. He retired, and then Tony Trombetta, and then after Tony came Kerry Berthelot, and then after Kerry came Megan Campbell. And after Megan came a new guy now, John Irwin.
But Doc Goodwin, we cut our teeth with him earlier. We did the NCAA championships in New Orleans. They had the NCAAs at Tad Gormley Stadium one year, and he was in charge of it, and we thoroughly loved him.
Bob Goodwin's a character. He's one of the old dogs.
Yeah.
Well, for the Sports Medicine broadcast, again, this is Dr. Josh Yellen with the University of Houston Master of Athletic Training Program. Find us at www.hhp.uh.edu/MAT. You can look us up on Twitter at U_MAT. You can catch the Sports Medicine broadcast at sportsmedicinebroadcast.com and hashtag or at the Sports Medicine broadcast. Webb, thank you very much for your time.
Enjoyed it.
And we'll talk to you soon. Thanks.
Gotcha. Nice to meet you. No. It's been a few years. I left. I was at Elsa Classic. That was 7 years ago. So I she was really good. She was really close with Bill Wilson.
Yeah, she's really, Can you guys do me a favor? Could you sit over there and talk, just whatever you're talking about? We're actually going to show it live over there because they're killing time. So I'm just going to show it live.
So we'll kill the time.
Yeah. You just, because it's streaming live right now. So you're just going to sit there, whatever conversation you want to have. No, I thought Josh was still over here interviewing.
I see. This is the camera?
So I take it you're at NASA now?
Yeah, I work at Johnson Space Center.
Okay.
Astronaut Strength Conditioning Rehabilitation Program. Now Mitzi was in the group prior. She's now with University of Houston, and she's kind of like a half and half with the company that I work for in their epidemiology group, as well as University of Houston. She's a professor at U of H. So, but yeah.
Is she now? I didn't know that. Okay.
Yeah.
You want to stay on this conversation too?
Oh no.
Yeah, come on, you can stay here if you want.
I'm
We're
good.
live right now.
We were just we were filling.
Do you work? Have you worked with Smith Johnston? Dr. Smith Johnston, MD. Okay, because I thought he did some sort of work with I thought Continental.
Percentages are.
But I guess I'm.
Absolutely.
You have it.
I'd say in the truck. Let me go grab it. I'll bring it in.
And then once you have a seat.
Take care. Nice to meet you.
Be right back.
Was this like a college gig of yours? Were you doing the college radio thing or something, or what? Because you got these down pat pretty good.
Yeah.
We're gonna take a break, and we're gonna be right back with some Leonard Skinner, that kind of stuff. First, we got to pay some bills.
Okay, you ready? Hey, welcome back to the Sports Medicine Broadcast. I'm Dr. Josh Yellen with the University of Houston Master of Athletic Training Program. www.hhp.uh.edu/MAT. You can find us on Twitter at U of HMAT. You can catch us on the Sports Medicine Broadcast, which is really the brainchild of
They're actually watching live in there.
of Jeremy Jackson over at Pasadena High School. I'm sitting here to my right is Bruce Nischwitz, and right before Bruce we had Webb Miranda. Webb's an athletic trainer with United Airlines, and he was a high school athletic trainer for a while. Bruce, thanks for being here with us.
You're welcome. Good to be here.
So Bruce, a lot of people are unfamiliar with athletic training outside of that traditional athletic setting. And when they think about athletic trainers in other industrial settings, whether it was like at United Airlines with Webb or what you do, you're an athletic trainer with NASA. Tell us a little bit more about what you do.
Okay. Well, as an athletic trainer, I expected to be doing, really just pure athletic training type work when I first got there. When I interviewed, I was pleasantly surprised that there was a lot more strength conditioning and really hands-on work with crew members in the gym, as far as
And when you talk about crew members, you're talking about
the astronauts themselves, as well as the pilots that you might see flying around the Houston area in those little white planes.
They're called.
Well, it's the Aircraft Operations Division, so AOD, AOD pilots. Now, a lot of the astronauts are not pilots themselves, but they have to have flight hours in aircraft, and they do different types of things in aircraft, so they need pilots to fly them around. So we have a whole other group of pilots that work at Ellington Airport or Ellington Field, and we're responsible for their care somewhat too. They will come to us if they have some sort of aches and pains.
So tell us about the team, right? So first of all, before we get into that, tell us a little bit about your background. How did you come across this opportunity? Because I'm sure there are a lot of people listening, either whether they're listening live right now across the room from us, or they're tapping into the YouTube or the podcast, and they just heard Webb Miranda talk about his job over at United, and they may say, hey, you know what, I want to transition into the industrial, occupational side of athletic training. Mm-hmm. How did you get this opportunity with NASA, and do you work, who pays you? Is NASA that pays you, or do you work for another contractor?
Yeah, I work for a company called Wiley. They have been contracting with NASA for as long as I know. I've been working there, obviously, and many years before that. So I really didn't know that there was an athletic trainer at at NASA per se years ago. I was working at Alvin High School. Originally, I started working for St. John Hospital Sports Medicine, and I was assigned to Alvin High School as their athletic trainer, their clinical outreach athletic trainer. And after a number of years, that contract was ended. And the high school obviously needed somebody to be their athletic trainer. I approached them and said, hey, it's, I'm either gone or we can create some sort of position, which they were happy to do. And I worked there for another 5. So I was at the same high school for 9 years, more or less doing the same thing, head athletic trainer duties. And my wife, who I met at that school, left the teaching profession, and she'd always, either wanted to be a teacher or be in some sort of NASA-related type job. That was one of her dreams, I guess. She was able to get a job there a couple of years before I did, and because she was able to get that job, she met the different people and heard about the program and told me about it. I remember her specifically talking about it, and I said, they need to have athletic trainers over there taking care of those astronauts. They get a lot of training, and they have to climb in and out of that suit, and they're in that gym, and because I'd heard about that they had this astronaut gym. And she said, well, they do. It's called the ACER group.
Yeah, what does ACER stand for?
Well, it stands for Astronaut Strength Conditioning and Rehabilitation Group. So
and,
they have,
if I'm not mistaken, the NATA came down and they did a nice little article about you guys, right?
They did. They came down for a day out of Dallas, and we spent the day showing them around NASA, showing off what we do there, and more or less just sitting down, chit-chatting with them and doing interviews.
And so what are some of the things that, obviously when you and I were coming out of school, similar to what Webb was just sitting here talking about, similar to some other athletic trainers, when you and I were going to school, we learned all about, the prevention and the diagnosis and the rehabilitation, the immediate care of these traditional athletes. Mm-hmm. And now we're really kind of transitioning into something called occupational athlete. Mm-hmm. So what are some of the things that these astronauts are doing on a daily basis where you as an athletic trainer need to understand the biomechanics, understand the movements, understand some of the rehabilitation activities that may be a little bit different than what you learned in the traditional settings?
Well, I think the main reason why we would consider an astronaut in that area of occupational medicine, and I say that there's probably one caveat, and that is some of the things that they have to deal with when they're performing their job is obviously out of this world, right? So there's zero gravity. They're on the space station.
It literally is out of this world.
Literally out of this world. Right. So it presents a number of challenges that a normal setting, or even outside of the normal setting, would ever really have to deal with. But it's still part of their job, and they still train many hours to perform those tasks on the space station. So because they're training all those hours, whether it's in a spacesuit that's, you might think of as at least on Earth as like a mini submarine, mm-hmm. or on orbit like a mini spacesuit, or a spaceship, excuse me. All those hours of training in the suit, or training in cramped quarters, or training under just strange environments, it really adds a uniqueness to my job, and I think it's outside of what I would have ever imagined having to do with athletic training. It's not contact sports, or it's not just simple overuse injuries. They are overused, but it's specific, I guess you could say, to their environment.
So a lot of times, if I look at it from an athletic training education standpoint, we have to meet certain standards, and one of the standards is they have to be in an individual or a team sport, and it has to be a sport with equipment-intensive type situation. Is there anything at NASA where it's there's equipment intensive that you guys have to be aware of?
I would say that the what we call the EMU is the Extravehicular Mobility Unit. Everything in NASA has some sort of acronym or initials, similar to the military. So that would probably be the number one thing. The EMU is the spacesuit that they have to practice wearing in the big giant pool called the NBL, which is the Neutral Buoyancy Lab. It's I think it's still the largest indoor swimming pool in the world. It's 40 feet deep. It's 100 feet wide and 200 feet long. I don't know how many gallons it is. I suppose we could do
A
some
lot.
quick math and figure that stuff out. But so they have to climb up into this suit. It's many parts put together, mainly into two main pieces. You have the hard upper torso and sleeves and arms, and then you have the pants and boot. You slide into the legs and the boot, and they weigh probably 100 to 150 pounds.
Just the legs and the boot.
Just the legs and the boot, and
Right.
then you kind of have help carrying yourself around, getting to the platform, where you have to then climb up into this hard upper torso and sleeve.
And does that weigh
device.
about 100, 150 pounds?
Yeah, it's about the same weight. I
So they're
think it's
walking around with 300
something.
pounds of gear.
They're not necessarily walking, but they are wearing it. Now
Right.
they're bolted to a platform rack on a crane
Mhm.
when they're going, lifted into this big giant pool. So you have to climb up into this thing, and it's if you kind of think about how it might have been for maybe a knight back in the Middle Ages or whatever to get into a suit of armor, it'd probably be
Right.
similar. It's quite difficult to climb up in there, and your shoulders are contorted, your arms are contorted to climb up into this thing, and you kind of ease yourself in, and it can be difficult, especially for someone who has a little bit of a lack of range of motion. I've had to do it a number of times, just so they gave us exposure to what we might experience, and it's not the easiest thing to climb in there. I had a little bit more success with it, I think, than some other folks. I just, maybe because my range of motion was different, or the way I'm built,
Right.
I might fit the suit a little bit differently. But I didn't hurt myself anyway, knock
Right.
on wood. So
And how many times, right, these astronauts, it sounds like, and again, for, you and I work together every Monday.
Mhm.
Right? I go down there, and as part of my job with the University of Houston, I work with the ACER group, which is an incredible opportunity for me and really unique, and I really appreciate what you guys are doing down there. And, I've gone through a lot of education there. But there are a lot of people that are listening to the radio, or even people that are listening to us live right now, that they've never even thought about being an athletic trainer with NASA, and they've never really thought about these things that you're talking about.
Mhm.
So it sounds really like you need to be able to take a lot of your education, and if we look at the new practice domains of athletic training, where prevention and wellness, protection, health promotion, it sounds like you're doing a lot of that, like Webb is doing over at United.
Yeah, I think it fits into that scenario really well. The injury prevention part probably is what David and I try and focus on the most as athletic trainers.
Now, who's David?
David Holan is another athletic trainer that I work with. He's one of the 3 people in my group currently.
And who's the other one?
Mark Gilliams.
Uh-huh. And is Mark also an athletic trainer?
He is not. He is a certified strength conditioning specialist, strength coach.
So you have 2 certified athletic trainers.
Mm-hmm.
And tell us a little bit about that. You both have bachelor's degrees and you both have master's degrees, or how? If somebody is looking to try to duplicate this, what kind of education do you think they need?
I think originally NASA didn't have a whole lot of knowledge about athletic trainers in general, and I don't want to say they weren't selective, but I think it was probably if you had good experiences, they were willing to, hey, this person is really qualified. These days, with it being just a little bit more tightly controlled, I think, and just more popular, I think they're able to select people with, I think, a little bit longer experience time. If you looked at, say, my resume to anybody else's resume, that even somebody straight out of college, it probably wouldn't be all that dissimilar, right?
Mm-hmm.
We'd taken the same coursework, and we had similar experiences in undergrad. But I was an athletic trainer at a high school for 9 years, and
So similar to what Webb did. Webb was also a head athletic trainer at high school.
yeah. So I don't think that this type of job that I'm in now is something that we would just take somebody straight out of college. I think that it's something that you have to actually go out and get some experience doing, whether it's at a high school or it's a college setting, or even in some setting like that he's in with the airline or military, something that's where you're just, you're successful at what you're doing at that particular time. They're not necessarily looking for one group or one person from one area. They wanted to bring in different types of talents.
Yeah, it's
and
not
put them
necessarily
into
a
a team.
prototype.
Exactly. There is no prototype for what we do. It's just that as a unit, as one unit, we're a couple different parts, and those parts still got their experience from someplace else, right? So it's not something you can just move right into. So
it's really interesting, in the athletic training world, you have a lot of people that, you are trained in a specific setting, and for a lot of people it's hard to move outside of that box of comfort. And it sounds like you took that specific training, and then you moved your box and got outside that comfort zone and applied it.
Yeah, people have said, "Oh, Bruce, you're so gutsy. You've taken these chances." And I was raised in Ohio. I went to Kent State University. Went to a graduate assistant position in Mankato, Minnesota, and I didn't know a soul there. And they, I can't believe you're leaving. You're just moving off, and you're just going and doing whatever. And I was like, well, I'm going to go to school. I'm going to go to graduate school. It's like I'm not going forever. It's only a 2-year position, and who knows what's going to happen after that, So, who knows what happened is that I had nothing going on after graduate school. I'm like, what am I going to do? I got to find a job. Everybody was either turning me down or wasn't really paying attention to my resume that looked just like every other postgraduate person.
So everybody that's coming out of school has got the same essentially experiences and qualifications and education.
I've had to do some hiring on my own from when I was at the high school, and it's some are, I know I don't necessarily want this person. They just don't meet the qualifications. But it's amazing how many look identical. And when you start talking to people, it's even more so, I think.
So you go back to a unique concept and something that we tell students all the time, and this is something that Jasmine and I, Jasmine, you and I had this conversation. What's going to separate you from the rest of the pack, right? Everybody's going through this education.
Yeah.
Everybody's got all the same coursework in the same order, and now obviously with the new Katie standards, and everybody's doing the same thing. So what's really going to separate the student from the pack?
I don't know that I even had anything on my resume that separated me other than years later I had the experience. But I think that if I was to talk to a student now, I would say take some chances and go outside of the box for sure. Don't be afraid to move away, for one. Like I said, I moved from Ohio to Minnesota without knowing anybody, and when I came down to Texas, I only knew just a couple of people in the state, and it's a big state.
Yeah, it's the size of 5 states.
Yeah. Unless you live in Alaska, right?
Yeah.
So, I didn't know anybody in the Houston area really that was Hispanic. Well, I knew a family in Katy, but I didn't know anybody in this profession anyway. And my closest friend in this profession was over in Copper's Cove, which is on the west side of Fort Hood. So that's many hours away, and he was instrumental in getting me down here. But it wasn't like I could just call him up and we could go grab a burger. It was
because you lived 10 hours away.
Yeah, I lived way over here in Houston. So, coming down here was obviously what was supposed to be for me. It was nothing that I ever thought would ever happen. I never expected to leave the Midwest, but it happened, and I really enjoyed here. I've been here since 97.
So you've been in Houston since 1997. And 9 years of that you spent
at Alvin.
At Alvin. Yeah. So that was up until 2006. And then after 2006, after you leave the high school athletic training, so let's back up, right? You come out of undergraduate in Kent State.
Yeah, in 95.
Then you go on to be a graduate assistant at
Mankato State University.
Mankato State in Minnesota.
Now called Minnesota State.
Yeah, and you leave there in what year?
97.
You leave there in 97, and then you come down here in 97.
Yeah. Kathy Schupak, which some people might know her around here, she worked at Clear Brook, very active in the Texas State organization. She is a Southwest Texas State grad. My friend Dan went to graduate school there. He and I went to undergrad together. He was working at Copper's Cove High School. At SWATA, they had a little luncheon. He shares an elevator with her. He overhears her talking to another colleague. Man, I gotta fill this position down there in Clear Lake. I have a high school job through St. John. He says, I can have him down. I can have somebody there in a week, just out of the blue.
So again, it goes back to something that Webb and I were talking about, right? So that kind of Kevin Bacon's 6 or 7 degrees of separation.
Yeah.
So
shared an elevator. They didn't even know each other.
You're in an elevator, and he goes out on a limb for you.
I wasn't there. I was actually up in Minnesota.
Right. So, but he's in the elevator, right? He goes out on a limb for you, and you don't necessarily know Kathy, but
Not yet,
through
no.
through this relationship, he says, "Hey, I've got somebody for you." And you know what? If you hadn't done a good job all those other years, he'd look like a moron. But he
Yeah,
doesn't, right?
probably.
You come down and you're there for 9 years.
Yeah. He said, I can have somebody here, in a week if that's what you need. She says, well, do you have his resume? No, but I can get it to you within an hour. I just have to make a phone call.
Mm-hmm.
So he wakes me up probably. No, but I'm just kidding. He gives me a call. I send it down. That was fax days back then. That was not the emails.
Jasmine, have you ever seen a fax machine before? You have. In the Smithsonian, is that?
Yeah. Yeah. So he says you got to fax this, fax that stuff down there. I did. They called me, asked me for an interview.
Mm-hmm.
That was Rick Carboni. He used to be the director of the sports medicine group over at St. John.
Mm-hmm.
And they offered me a position. So I was the outreach athletic trainer for 5 years from St. John. Contract ended. I went to go to the high school as a
So you're there for another 4 years,
another
and then
5.
Another 5 years, and then after that, you leave the high school setting.
Yeah,
and
my
you
wife
go
said, "Hey,
to-
there's a position open at NASA, right?" Because we had heard, we had talked to each other about this group, and she says, well, I had met Mitzi Laughlin at a Jihad's Christmas.
Let's back up for those that don't know. Mitzi is our current SWATA president, and she works with me at the University of Houston. She's a research professor, and then she's also got.
She used to be an ACER at
right. She was an ACER at NASA,
and she was our manager. And I just happened to go to that Jihad's Christmas dinner at Rice, and my wife said, "Hey, that's Mitzi. She works with that group." So, she basically introduced me. It's amazing. My wife did all this for me. Not that we don't get along, but she's not an athletic trainer, right? So, introduced myself to Mitzi. Hey, it'd really be neat to get involved with something like that.
Yeah,
She says, well, we don't have any openings right now, but, keep us in mind. Mm-hmm. So I did. And when an opening came up, my wife, sure enough, said, hey, there's an opening. If you want it, you should put something in for it. I looked at it like, well, it's NASA. They're probably not looking for just some guy that works at a high school. They probably want someone with specific experiences. But the worst I can say is no, right? So I got my resume together, submitted it, got an interview. They hired myself and David Olin, and they were looking for 2 people. And
right.
David came from a college setting, I came from the high school setting, and we're both still there.
So it sounds like all of your experiences led up to this one specific opportunity, in that you're really able to take these different domains of athletic training, prevention, health, wellness, protection, and then how much immediate care in your setting. We spoke to Webb, and it sounds like he's really out in the area, and he's going to visit these people that work for United, and he's got a little bit more immediate care, I think. But tell us about the immediate care of astronauts, because I'm sure people are thinking, okay, they're up on space station floating around.
Yeah.
Tell us some of the things that you deal with on the immediate care side.
Well, it's a good question. It's really tough to tape an ankle on orbit, but it's not as hard as making Gatorade,
right?
Because the powder just goes everywhere.
Yeah,
it's crazy. No, we don't see a lot of acute injuries per se. Now we'll have something that maybe will happen in the gym. Somebody gets banged up or cut up somehow, or in some other training area. But we have a whole flight medicine clinic that they're supposed to report to for all those types of things, and we have a bunch of doctors that would take care of them, and nurses. We have a full staff, so we don't have to deal with that type of acute care like I used to have to do at the high school. I'm not putting Band-Aids on people left and right, and I'm not taping up ankles, and I'm not. But you do have the occasional blister that somebody might develop, and we have a full athletic training room right there where they do their exercise routines, and then they can go out running and, hey, can you take a look at my foot? I think I've developed a blister. Or, hey, I kind of jerked my wrist or something when I was lifting, or can you maybe tape that up for me?
So you're really doing a lot of prevention and health promotion. You're doing a lot of some immediate care, but you're doing a lot of rehabilitation, and you're doing some.
Yeah, it's mainly the post-injury send us from the doctor if they come to us, or they come to us and then we evaluate them, send them to one of our doctors. They turn around and send them back to us for the rehab then.
So now let's transition from the astronaut here on Earth, right? And then they go up in this little rocket.
Big
rocket, and they take off. And how fast are they going, you think?
They reach 17,500 miles per hour.
So they're moving about
Mach 25.
Yeah, it's Mach 25.
Mach 25.
So you're moving 17,500. And how long are they in that position for? to get to the space station.
Well, it used to be like 2 days they'd be stuck in that tin can, but now it's, I think, a 4 or 5 hour ride.
4 or 5 hour ride
Yeah.
going at Mach 25.
Yeah, not at first, obviously, but it
You got
gets
to
there
overcome
pretty
all
quickly.
that thrust, right? And so then they dock to space station. How long are they up there for?
They're up there between 5.5 to 6 months.
And so I'm sure a lot of people that don't know anything about physiology are thinking, boy, you're not in a gravity-dependent situation. There's got to be a bunch of bone loss. Tell us about some of the stuff that goes on in your interaction with the astronauts who are up on station.
Well, speaking of bone loss, because of the microgravity or zero gravity, they start losing bone loss as soon as they start to pull away from the Earth's orbit. And obviously, it's not like you feel a switch go off. Oh my gosh, I'm losing bone. But it slowly starts to go away. And in the days prior to the days of today, where we have the equipment that we have up there, we had some equipment that was just not as capable.
Mm-hmm.
We would see losses of 1% a month, which is much, much higher than anything we see on Earth as far as osteoporosis.
Right.
So it's real important for an active crew member that's going to be launched or preparing for that flight to build as much bone mineral density as they can prior to that flight. So that becomes even more reason to stay active and fit and do lots of weight training, because it's really the best way to put on bone, especially in the hip.
When they're on station, right, and describe to some of the listeners, if you can, you take off on this rocket and you bring a couple 25-pound dumbbells with you? What happens?
Yeah, it's the ones that you can put the pins in and give you the more.
Yeah.
No, they have 3 devices on orbit. They have a cycle ergometer. We call it CVIS. Again, that's crazy NASA stuff. Yeah. Cycle ergometer with vibration and isolation and stabilization.
Okay.
That's a mouthful. So CVIS. CVIS is just a basic cycle. It's an ergometer. You pedal on it. It doesn't have a seat. It doesn't have handlebars. It's attached to a big steel rack, aluminum probably rack actually, that has these little shock absorbers on it. It bounces around like a bucking bronco. You have to learn how to ride it. It's probably really tough to ride, but they ride it at least every other day probably. That their protocols are established between work with our group as well as the exercise lab who does the VO2 max testing on them. And we develop maybe 5 or 6 rides that they do that, change wattage.
Okay.
The treadmill is the 2nd generation treadmill.
So what's that called?
We just call it T2.
Treadmill 2.
Treadmill 2, yeah. The first one was called TVIS. Again, treadmill was.
So you had CVIS and then you had TVIS.
Yeah.
Okay.
Yeah, T and then VIS. So the VIS is the vibration, isolation, and stabilization. So it's the 2nd generation treadmill. It's a Woodway based treadmill. Woodway, I believe, is a good product. It's a good off the shelf company. So that treadmill is been kind of tweaked by NASA. It has an additional motor that can go in reverse. I shouldn't say reverse. It resists the belt from spinning. So I shouldn't have said reverse. Not that it spins in reverse. But it also has little force plates in it that can measure load and impact loads and stuff like that. So the exercise physiology people can get a lot of data from it. And we can design programs really any way we like to on that device.
And then talk a little bit about the weights. We said when the astronauts are packing up to go up to space, they throw in a couple of the 25-pound weights in their to-go bag.
Yeah, so now we have our weight training device, or our resistive exercise device, ARED, which is the Advanced Resistive Exercise Device. And it works. It's a pretty big device. It's very robust. Basically, the resistance comes from two vacuum cylinders. They supply 300
Similar
pounds.
to like a syringe plunger almost.
Yeah, if you think about it in that manner, maybe I guess a syringe plunger would probably be the easiest way to describe it. 2 of those canisters supply a constant load of 300 pounds resistance. Now that piston on the syringe is connected to well, I can't really think of what it's called right now, but anyway, it's connected to the loading, what's it called? LAU. That's what it is. Load adjustment device. So it's all this NASA stuff.
I understand.
Acronyms.
I understand.
So anyway,
my first day there, I didn't understand anything, including how to get to where you were.
Yeah.
And I almost got kicked out by the NASA police.
Well, to think about the way the load is if you think about that piston on the plunger, if it's connected to, say, a teeter-totter,
Mhm.
depending on where you connect that piston to the teeter-totter, because it's a lever system,
Sure.
will increase or decrease that load based on the mechanical advantage. So
Sure.
we can crank a dial towards the fulcrum or away from the fulcrum, or I should say move the fulcrum towards the center or further away. So that's how we adjust the load.
Mhm.
But it's a constant load of 300 pounds
Mhm.
per cylinder.
300,
so it's total
600 pounds total.
Mhm.
Yeah, that's a lot.
Yeah, it is a lot. We have really strong astronauts.
Yeah.
Now we have to compensate for body weight because we're in microgravity or zero gravity. Our body weight is obviously not felt. We're always carrying it on Earth, so we have
Right.
to add that back into anything that we lift.
So if somebody weighs 200 pounds and they're lifting 300 pounds,
yeah,
you have to compensate for 500 pounds.
yeah, we don't use the full 500, but
Right.
because such a large percentage of your body weight is below the waist, and if you're doing lifts that are, say, leg dominant,
Right.
like a triple extension lift, period, deadlifts or squats or something like that, we will add the weight back in. We don't add the same percentage of every lift. If they're carrying the weight on their shoulders like a squat or a heel raise or something like that, we usually go around 75%. If it's a deadlift, the ratio is more like 45.
And so let's go back, right? We've got CVIS, we've got TVIS, and we've got ARED.
Mm-hmm.
And these
T2
guys,
is the
T2,
second,
yeah, T2. And so we've got CVIS, T2, and ARED. And so you have an astronaut that's up there, and this guy's a real, we'll call it a gym rat.
Okay.
And so that astronaut's up there, and he's working out 8 hours a day, or are there specific things? Because really, it's really interesting, right? Because if on Earth, if we have a patient that needs to contact us, they'll contact us on cell phone and ask a couple questions.
Mm-hmm.
So this astronaut is going to be able to talk to you from space. How do they talk to you, and how long are they really doing some of these protocols for?
Well, they can contact us by phone if they need to. We've had probably a crew member per increment would probably call their ACER specifically and talk to them on the phone.
So let me get this
happens.
straight. You're out to dinner with maybe some family, some friends. The phone rings, and you say, "I'm sorry, I've got to take this
I'm
to
sorry,
space."
yeah, exactly. This is space calling. So it has happened. The worst is when they tell you in an email or in your video conference that we have once a week, hey, I'm going to give you a call to talk to you about such and such, so be aware. Maybe they're going to call you on your birthday or something like that, and then you miss it, because you have the phone in your pocket or something. And then
I'm sure that's if like you're in a meeting or something and the phone rings. I mean, that's a real. Sorry, I've got to take this. What's so important? Actually, it's space.
It's happened. Yeah, I was in a meeting one time, and we were talking about that specific person because they were a sprint subject, and that's one of the payloads that goes on payload. It's one of the science experiments that's going on. So they were talking about that specific person. I said, "Excuse me, this is this person on the phone
Calling from space.
Hey, how you doing? Okay, we're
Right.
talking about you in this meeting."
That's pretty good cell reception.
Yeah, I have Verizon.
That's right. So if anybody's from Verizon, they're looking. That's a little plug for
Can you hear me
Verizon.
now?
Yeah, can you hear me
Yes,
now? Yes, I can hear you
yes,
from
I can.
space.
So they'll call you from space, but we have email capabilities, and we have a video conference. It's scheduled throughout through once a week contacts with them through the flight medicine people. So
So it sounds like you're able to talk to the astronauts just like any other athletic trainer would be able to talk to their patient.
yeah,
It's just what you do is a little bit different, similar to again when Webb was here and is talking about what he does for United. You're taking a lot of the skills that you learned as a clinical athletic trainer, and you're applying them and you're adjusting them.
Yeah.
And you're applying them to the NASA setting.
Yeah, I wish I could just pick up the phone and call them when I have a quick question and ask them. But unfortunately, I have to either email it or wait until the following week to ask that question. But usually we do it through email, and they're pretty quick to get back to us. They
Did they
understand.
ever text message you? Did they ever take a selfie of themselves and send it to you?
I've gotten many selfies from those guys. They take these little pictures inside the cupola with the Earth, or cupola is like you think of it as a big bay window,
Yeah, sure.
and looking out towards Earth, and you see them floating there, and they have this picture aimed towards them, and it must be a heck of a life up there.
So I think it was the April edition of the NATA News, right? It comes out
yeah.
with a nice
Yeah, they did the
a
cover
nice
story. On
Yeah, a
us,
nice
yeah.
cover story about the Acers, and then I was fortunate enough to get a little bottom section about our new program and our interaction.
Josh, that was what everybody asked me about. They're
What's
like
that?
they were saying, hey, I see you got that. I see you got that article. Well, who's this Josh guy? They kept
No.
asking me.
I don't think so. And then this last cover is another astronaut.
Yeah, Mark Kelly.
Mark Kelly,
Yeah.
and I read the article. Thanks to you pointed it out. I hadn't had a chance to read it, but I got it and I opened it and I read it, and sure enough,
Yeah,
he
will
plugs
be the,
athletic training.
he will be the keynote speaker at the NATA convention in Indianapolis here at this. What is it? 2 weeks from now?
Yeah, I think it's 2 weeks. Yeah.
So I talked to him last Friday. As a matter of fact, he was at Johnson Space Center, and I thanked him personally for what he said about our profession. And he's a cordial guy. Thank you. You're welcome. Kind of don't remember exactly what I said, but you say it was good. I said, yes, it was. It was
Yeah,
good.
it was
Nice
great.
words.
It was great. I read it. I was really appreciative of it. And I think that you and David and Mark over there, I think you all are doing a great job. Again, I only get to really interact with you guys on Mondays, but you have such a unique job, and I think that the exposure of the three of you has really led to a lot of questions, at least from the athletic training education side, that when I have people apply the program, they go, hey, I saw this article, I heard about it. And now you've really got the cover story of you guys in April, and now the cover story of Mark. So there are two promotions for athletic training in these non-traditional settings. They're really promoting what you're doing.
Yeah, we've been fortunate, I think, in the past year, obviously. This is one of the goals that I had a couple of years ago, and Dr. Greg Shashkin was involved with our group, and unfortunately he passed away. But when he sat down and he said, what kind of things do you want to approach? And we, obviously the stuff that was directly related to our work was on the list. And what about the outside of the box stuff? Or what about, just promoting the group in general? And I remember saying specifically, I think it would be neat if NATA was able to do a story on us. And so that was put on the back burner for quite a while. But it came up, we did it. And I was glad to be involved in it.
Yeah, that's good. A couple last questions here for you, Bruce. If obviously you and I have had some private conversations about athletic training education, and I seem to get a lot of those questions all the time, that when they find out this is an entry-level master's, everybody seems to have an opinion about what we're doing right or what we're doing wrong, or what should change, what shouldn't change. If you were going to give some advice to a student, whether they're coming out of a undergraduate athletic training program or a graduate athletic training program, even a post-professional master's, what's some of the advice that you would give to somebody that's thinking, you know what, I don't really want to be in the traditional setting. I really like what Bruce is doing, I really like what Webb is doing. How do I get into something like that? What's a piece of advice? And then, from the athletic training education side, if you were to give me a piece of advice of how do I make some of these students more valuable in what they can do? So the first question is, what's your advice to the student? The second question is, what's your advice to me?
Okay. The first, according to or as far as the students go, I would tell them, number one, you have to get experiences in different areas, just like what Webb said. Now that doesn't necessarily mean that you have to go into a totally different profession. It just means that you just need to get some different experiences. One of the things that I was involved with indirectly and accidentally was there was some kids at Alvin High School that did rodeo. A funny story with that, we had a kid that was a JV type guy, and he says, he's coming in, he's always banged up, and I'm watching him at practice, and he's more or less standing around at practice a lot. How do you keep getting hurt? Well, I'm hurt. Oh, what are you doing? Are you playing some kind of club thing? No. And it turns out, he finally tells me, well, I'm a bull rider. Because I'd been kind of hammering this kid, like, there's no way you can be getting hurt all the time if you're not doing anything in practice. I'm watching you. Finally tells me, bull riding. Oh, well, why didn't you just tell me that in the first place, right? Those things are going to hurt you. They're trying to kill you. So after I told him he was nuts, I took care of him. So I started, exploring the whole rodeo thing a little bit more. I never really worked with rodeo other than some of the kids that came to me, and then you just learn a little bit more about it. Now, I wouldn't call that the same type of experience that obviously the Justin Sports Medicine people work with, right? But you still see things from a different perspective.
Sure.
And when they explain all these different techniques that they have to do to grip the thing, or where they, how they got flipped off of it, or whatever the case may be, it just gives you a little bit different idea of what they're going through. I think that kind of stuff, be open to different avenues And I
So-
think you have to be able to travel. I mean, as far as, you might have to move away from home. You need to get
So
someplace
you're really
different.
kind of hovering on that theme of, you got to get outside your box.
Yeah, you got to get away from the comfort zone.
And then
And
from
if
an
it takes
athletic
moving
training
from mommy and daddy, you might have
got to
to
be
do
able
it.
to do that.
Yeah.
And then from an athletic training education side, you and I have had some conversations privately.
Mhm.
Yeah, but I'm interested, right? So to say, how do I better prepare, right? Because you've got some experience. You were at the college level. You were, at Mankato State, and then you were at the outreach level, and then you were at the high school, direct high school, and now you're in the industrial side.
Mhm.
So from an athletic training education standpoint, both for my knowledge and the knowledge of all the other program directors out there, what's one thing you think that we need to know to make these students more successful?
Yeah, I at Kent State, I was in a internship route.
Yeah.
Now, some people would look at the internship route from years ago and say that they were just getting abused. They were slaves. They were just cheap labor, which in many cases it was true. There was probably schools out there that just used those kids to get water to the athlete.
Mhm.
I feel that where I was, they were honestly trying to prepare me for the profession. There was only about 8 to 10 of us, so we had a lot of work to do.
Mhm.
And it's a Division I school, right? It's a lower level of the Division I, right? It's the MAC, but we still had a number of sports. We were still catering to the same type of athlete. We just weren't in the SEC. So those experiences were tremendous. They were crushing as far as the amount of time. I mean,
Right.
you had to put in so much time.
Right.
If you can somehow extrapolate those types of experiences in the sheer amount of experience that we got hands-on
Mhm.
to the students that are in these modern day curriculums, I think it's just.
So it sounds like we really need to find a fine balance
Yeah, and
between
that was
theoretical knowledge and clinical knowledge.
and that was exactly what I said when they first started talking about going away from internship route and going to just all curriculum.
Mhm.
They said we're going to do away with the internship routes, and there was a lot of old timer internship people. Oh, you can't do that. That's just a horrible idea. These kids are not going to know anything. Didn't turn out to be that way.
Right.
I didn't think that it was necessarily a bad idea to do away with it, as long as you somehow kept what the most valuable part of what internship was, which was the true hands-on
Yeah,
experience.
that clinical experience. Well, I'm glad you said this, because one of the things that I really looked at in this program was obviously that theoretical knowledge, but by the time they come out of this program, they're going to have 1,400 hours of clinical education experiences, which I think is really going to set them apart from some other programs. And the amount of diversity that they have here in Houston, who they're going to be working with, I think is really going to be a real asset to them in the program. And
Yeah,
to
there's a
us.
lot of opportunities. You have ballet, you have professional sports, you have collegiate sports, you have
Right.
NASA, you have you name it.
Yeah, we have
rodeo,
United Airlines now.
and
yeah.
United Airlines. Yeah.
Yeah.
So it's a good area to be.
Well, they're giving me the sign that I got to wrap this up. So for Bruce Nischwitz, Bruce, thank you very much. And
You're
on
welcome.
behalf of the Acer Group, I got to tell you again, Mondays is always a joy for me, whether it's something that we got to do, whether it's hard, whether it's easy, whether it's time intensive or not. It's always a fun time down there on Mondays. So I appreciate you giving me the opportunity to get down there. For the Sports Medicine Broadcast, I'm Dr. Josh Yellen with the University of Houston Master of Athletic Training Program. Again, you can find us at www.hhp.uh.edu/MAT. You can look us up on Twitter at U of H MAT. You can catch the Sports Medicine Broadcast at sportsmedicinebroadcast.com. You can catch them on Twitter at the Sports Medicine Broadcast, I believe. And for Bruce Nischwitz and the Sports Medicine Broadcast, thank you very much.
Okay.
Everything okay? Something wrong? That's a nice house. That means you haven't looked bad. Have you lost some weight? Oh my God, it's fat. Good job, Bruce.
Yeah.
The same thing I did yesterday. Hi, Josh. Hello, Josh. Nice to meet you. Tell me a little bit about your background. Came out of, so this is some of the questions I'm gonna ask you. Came out of, where'd you go to undergrad?
Ohio State,
Where'd you go to med school?
Ohio University,
And then where'd you do your residency?
Ohio University up in Toledo. So I guess Toledo, Ohio, did my residency and fellowship here at Campbell.
Right, and who are you with now?
UT.
Okay, with Walmart. Okay, so, I'm the director of the Master of Math and Training program here at University.
Okay.
So we just signed a nice affiliation agreement with you. So, Lo, from being our ENT educator for example,
Great.
we're gonna be up there tomorrow. They're not gonna rotate with you until year two. But we're gonna stop by tomorrow. We're gonna be up there. We're gonna stop by tomorrow. Just so they can see if somebody.
I was an athletic trainer in a former life. I was a student at Ohio State.
Well, that's something you can bring up.
Right. I did my master's at LSU, so I was a grad assistant at LSU. Yeah. 94, 96.
You know what?
I do. I just ran into him in there. I was blown away. I had seen him.
Yes.
Yeah.
Right, I was in Southeast. Is that right? So here's another example. That's great. So you have Jeff Schmidt. So Jeff and I, when I got to Southeastern, I ended up becoming permanent director before I came here. I was responsible for pulling Jeff and his sports medicine program into our athletic training. So we know a lot of the same people. So Jack, Shelby, Andy, all those guys. Right?
How long were you at Southeast?
I was there for 10 years. So
You
from
know,
04 to just recently.
okay. Yeah, because I left, after I left LSU, I took a teaching job at Marietta College, in their undergrad program, sports medicine. I was there for about 3 years, and we had sent, we had one guy to a grad assistantship at Southeast at Morrow, but that would have been 99, right around 2000. So that's great, awesome. Yeah, and then I went to medical school.
So you were both your MD and
I went to osteopathic school. So
your
with
DO. Oh, great. Something else.
Okay.
So in graduate school, I took manual osteopathic manipulative therapy.
Yeah.
And so, and you know, when I was in grad school, it was professional masters.
Yeah.
And when I was leaving, when I was in the resident curriculum, our head athletic trainers. Yeah. Advanced mentality.
Sure.
I was called college osteopathic. Oh, no, we always called that. But I took 6 hours of manual therapy. And
Yeah.
I use manipulation skills all the time.
Yeah. Also energy, and that's, you don't need to, just so you're not doing like the high velocity, low amplitude, taking somebody's neck to Cleveland and stuff like that. But that's the stuff that you can do every single day.
Right.
And it's muscle physiology.
So this is the same stuff.
Easier.
So we're gonna use, so this is some stuff that we're gonna talk about. Okay, you appreciate that.
Mhm.
Wait just a second.
Yeah, man.
That's small world, so we're
It's
gonna talk
amazing.
about, oh,
It's just incredible.
yeah, so, I did my master's in California. On the way, coordinated program director, got my doctorate. And then, all these experiences, opportunities, use something we essentially call like, look, run this master's degree.
Great.
Okay.
Yeah.
You're in, you've never had anything like this before. You built it based on your vision over the last 12 years. I gave this straight. I'm graduate faculty. I built my own program. Tier 1 university. Fourth largest city in the country. I have access to all. Okay.
pretty nice.
And then on top of it, the guy that just left Force Initiatives, on Mondays, I want to ask you about so it's just one of those things. I've been thinking about this for all that time. So you probably also know Linda Bobo. She came out. No, she said Southern. She was there.
Yeah.
Sorry. Ray Castle was there. Jess Schmidt. Schmidt. All right, so we'll talk about it.
Good.
Let me just peel.
Take your time. Yeah. I think that's okay.
Thanks.
Yeah, kidney function is important.
Yes, and you took, and I'm going to ask you about that. You kind of had an non-traditional route to medical school. Yeah, and then why did you choose DO over MD? And I'm going to ask you to elaborate.
Yeah, no, I chose specifically DO or MD. Part of it was the way it just felt for me. The other part of it was I felt like with the DO approach, I was getting a little bit more in my kind of, as an athletic trainer, you look for as many advantages as you can. Right. You know, why do athletic trainers have this laundry list of initials after the right? Not enough. No, now it's LAT and CSCS and wherever else they want to grab. Right. So they're constantly grabbing and looking for these things. So people think, you know, an MD degree, it's just you know everything about it, but you don't. Right. And at that time, I was coming at it from a different point of view, where I thought, well, from a sports medicine standpoint, this is going to give me something a little bit extra.
And I'm sure the osteopathic education, the athletic trainer education, both physical medicine, right, it fits very well.
Right. Yeah, and that was the biggest part. It was a feel thing for me.
Holistic healthcare.
And that's the other thing too. You know, I mean, it's osteopathic medicine started, was founded by an MD.
Andrew Still.
That's right. And he was at the time, this is the late 1880s, he was fed up with modern medicine because it was killing people, it was killing his family members. He was a very religious man. He thought, you know, Maker, he creates us in such a way that we can heal ourselves, but we have to set the body up. And so basically his basis was the build and the alignment of the muscle skeleton.
That's really what we know is physiatry.
Some elements of it.
Some
elements of it.
All right.
And even that's become somewhat metamorphosized, something that it was never meant to be. That's exactly what it is, yeah, injections or, right. And so, and it's unfortunate, but that's, you know, go where the money is, I guess.
And so let me ask you a question, as an osteopath, do you still keep up your manipulation skills?
From a personal standpoint, I do.
We're still manipulating some people.
I'll do it on occasion, on patients who come in, you know, I'm an upper extremity guy. So, you know, a lot of what I'll do is if you're still adhering to some of those same basic principles, I would say. And I'll simply work on more family members, and or I'll address problems like impingement syndrome and things like that, from a musculoskeletal standpoint, where it's these muscles in the upper part of your back, the scapular stabilizers, that's why conditioning naturally weak.
Maybe I got to release, you know, the upper thoracics.
That's right. So something along those lines, as opposed to, oh, you need to widen your subacromial space. That doesn't make any sense at all. Right. God put that there for a reason. And we're closing it down because it's the design. It's what we do. So, yeah, if we're just better conditioned, we're not slouched forward.
You know what's so funny about this? Is, when I was in graduate school, our head athletic trainer, Dan Bailey, Dan, you know, walk in and we're all grad assistants. Dan says, anything you've ever learned about rehab, throw it out the window. You will use maybe a modality. And it was all about, you know, in that Long Beach state, it was always big volleyball, big water polo, big swimming, you know, that kind of stuff. And so I remember, and this is before all the big stuff about like, you know, active release. We call it myofascial release. And so, you know, I'm working on this guy, strengthening his posterior, you know, stabilizers. Dan comes up, he's like, spec line. So we talk about spec line. What is spec line? Says, watch. Takes his thumb, does some active release stuff. Says, how does that feel? He goes, oh my God. What just happened? I'm like, what just happened? He goes, now watch. I'm going to manipulate these upper thoracic. See what you do. He's going to have more range of motion. Like there's no way.
That's cool. That's the cool stuff.
Yeah. I'm going to interview you guys. You both want to sit?
I got 2 minutes. I got a really room.
Okay.
What do we do?
You can go, if you need him, I'm happy to wait.
Is that all right?
That's fine.
Let me pee real quick.
See, I mean, I gotta go, I got one of the.
Oh, I'm sorry.
I'm gonna,
If you want, you take it.
well, it's gotta
Hey,
go.
hey, you gotta go.
It's got somebody
Go.
Just,
I
sorry,
mean,
guys.
somebody's waiting for you on the table, man.
That's why he made
I
it
gotta go.
That's a little important.
Yeah, that's why he made it very short.
They're asleep.
Very short. He has one on the OR table,
That's a likely story.
or ER table or something, I don't know. One or the other.
Well, I guess I can ask my question. Look up. Here's a question.
Is it like a live simulcast thing or what?
Yeah, it's what you're saying right now on your phone is possibly heard live. So it's just running continuous equals 4 hours.
All right, so Dr. Coop said he has a patient waiting for him at the hospital, so he couldn't join us on the broadcast today. But we have Dr. Copeland up next. He's going to be talking about hand, joint, finger, wrist stuff with Dr. Yellen once he gets back. I'm inside the main sessions recording, but Dr. Yellen is doing a great job holding down the fort here on the sports medicine broadcast. Jasmine's staying awake over there, doing a great job. So I'm going to head out here in just a second so I can get over there and make sure I get all that recording.
Doing all right in here, Josh?
Doing great. Hey, can I have that real quick?
For what?
Here.
Yeah. That's an evaluation. So you can just tear that out. There's different things. Like right now, that one's pretty well on that seat.
Koplinger or Koplinger?
That's Keplinger.
Keplinger.
There's no O.
There's an O, but it's silent.
That's right, yep.
This live part is through Google Hangouts on air, and it's all free. So if you have a Google account, you can do Hangouts on air. Yeah. Our school's all through.
Okay, so we're just gonna, there's the camera right there. You're gonna be on the sports medicine broadcast. And I'll lead in the introduction and then we're just gonna have a conversation.
Sounds great.
Sounds all right?
Mm-hmm.
Okay. Hi, everybody. Welcome back to the Sports Medicine Broadcast. I'm Dr. Josh Yellen with the University of Houston Master of Athletic Training Program. You can catch us at www.hhp.uh.edu/MAT. Follow us on Twitter, U of H MAT. You can catch the Sports Medicine Broadcast at sportsmedicinebroadcast.com or follow them on Twitter at the Sports Medicine Broadcast. Isn't that right? The Twitter handle? What's the Twitter handle? Hashtag PHS. There is no hashtag.
Hashtag VSMB.
Yeah, the hashtag VSMB and then at PHS Sports Medicine. To my right, I have Dr. Matthew Keplinger. And Dr. Keplinger, thank you very much.
Sure.
Tell us a little bit about your background. So you are an orthopedic surgeon. And as we were having a conversation before, you're a DO, but you have a really interesting background on how you got to where you are. So let's start way back from the beginning.
Yeah.
You are actually an athletic trainer.
Right.
All right. So talk to us. Where'd you go to undergrad? Where'd you go to grad school? What were you doing? How'd you get to where? Get me right to when you start DO school.
Yeah, I guess it started, I was at Ohio State for undergraduate, and then I did did an internship program
And what
there.
what year was this?
That was 94. I
So yeah,
graduated
the
in
accredited
94.
program really doesn't happen until about 2000, 2004.
That's right.
So you're going through the internship.
Yeah, we were slugging it out, and I loved it. Though it was one of those things that one of those things that just it kind of found me. I was interested in physical therapy, and it kind of found me. And so did that route. Went ahead and did a graduate assistantship at LSU.
Okay.
Worked there for 2 years.
And we were talking about that you and I have some common roads, and
Yeah.
that we were just talking with Webb Miranda before this. He's an athletic trainer with United Airlines.
United here in Houston.
And Webb said that he came out about the same time, and I said, I lived in Baton Rouge for the last 10 years.
Yeah.
And turns out that you and I also have some commonalities and people we know.
Yeah.
And one of the things that I've always said that's unique about athletic training is that you got the Kevin Bacon 6 or 7 degrees of separation, right?
That's right.
But in athletic training, so here's another example. You and I don't know each other till about 10 minutes ago.
That's right.
But boy, we know some people that know us.
That's
right. So I can get you through a few different ways.
Absolutely.
Okay,
Yeah.
so you do your graduate assistant at LSU, and what year did you graduate?
96.
Okay, and then after that, what happens?
I did a year with the Cincinnati Bengals, and still wanted to do that. But then I had this opportunity at Marietta College. I taught in the sports medicine department there for 3 years. That was a great experience, and somehow then I got a wild hair and wanted to give medical school a shot. And honestly, I'll tell people this all the time. I went to medical school because I couldn't get into PT school. It was one of those things you kept trying to do. It just wasn't going to work. And we all have a path laid out for us, whether we like it or not.
Right.
So that's kind of the course that I took. I was very, very fortunate, very blessed to be with some really great people at Marietta College up in Ohio. And I was able to kind of work through some of my prerequisites. And it was one of those things, I'm going to give this a one-shot deal. It was a great job. I still miss it to this day. But this was a path that was laid out before me. I went to medical school at Ohio University, and it's an osteopathic school.
Right, and they have a great post-professional master's degree with a guy by the name of Chad Starkey. And one of my former students, Jeremy Uze, came out of that master's degree. And you may have had some interaction. I don't know whether or not. But now Jeremy is finishing up the Doctor of Athletic Training program at Idaho, I think it is.
Oh, wow. That's great. Good.
Small world. Okay,
Yeah.
so you go DO school at Ohio University.
Yeah.
And let's stop there. So let's kind of backtrack a little bit. So undergraduate at Ohio State, graduate school at LSU, year with the Cincinnati Bengals. Then you go to Marietta College in Ohio.
Right.
And you start taking some prereqs. So you're faculty there, and you're taking some prereqs. And you said, hey, listen, I want to give med school a shot. What led you to the osteopathic path versus the allopathic? So a lot of people, like Jasmine, for instance, do you know the difference between an MD and a DO? Right. So a lot of people in the United States, they see the MD and there's name brand recognition, right? A lot of what we're seeing in athletic training, AT versus PT.
Right.
And so the DO is really an osteopathic. It's an osteopathic physician. The MD and the DO have all the rights of one another, right? You can practice a DO as a physician just like an MD. But there's two different philosophies, right? Allopathic versus osteopathic.
Right.
So there's some people that are listening like Jasmine who are juniors at Texas A&M. They're thinking about going to graduate school in athletic training. So please tell us the difference a little bit.
Sure. Osteopathic medicine was actually founded by an MD, Andrew Taylor Still, back in the late 1800s, so 1880, their range. He was a surgeon in the Civil War, and really was at some point in time, he's a very religious man, but at some point in time he got basically fed up with modern medicine, saw that as poison. And medicine is one of these things where there's a lot of obscurities. Why do you do what you do? Well, it's because that we don't know. We really don't know. And he built his brand of medicine on the basis of as a belief in a great creator that would provide us with the ability to heal ourselves. So he built all of this around the musculoskeletal system, and his saying is or was, the rule of the artery is supreme. So if he could manipulate soft tissue, myofascial releases, musculoskeletal alignment procedures, that would provide the avenue for the body to heal itself. Now, his initial brand of medicine was devoid of any medications whatsoever. Of course,
So,
this is
well, what we think now is chiropractic.
right.
Right.
Now they weren't, and that's an interesting point you bring up. They were, I guess they were, the founder of chiropractic medicine was actually a grocer, wasn't a physician, and they were contemporaries, but they were not colleagues. So I think, and again, it depends on how you look at the different points of view from the history. Osteopathic medicine is still built on the basis of treating the holistic person.
So let's go back a couple of sentences. The founder of chiropractic medicine, we'll say, was a grocer. Like owned a grocery store.
Grocery store. Right.
Okay, I understand. Okay, let's continue on.
Sure.
I just want to make sure I got that
That's
right.
okay. That's okay.
Go ahead.
Yeah. So the osteopathic brand is basically built on trying to treat the entire person and looking at things not just from a shoulder pain problem, but what's causing that shoulder pain. Is it weak or underdeveloped or deconditioning of the scapular stabilizers, or is it, as opposed to just treating shoulder pain? You're treating the cause of the pain, or maybe you're treating some of the other components that are affiliated with that, or the diabetes that somebody may be manifesting. How does that manifest itself, not just from a musculoskeletal standpoint, but from a holistic and entire systemic standpoint?
Sounds like everything you're bringing up is right in line with athletic training.
Right, exactly.
So I could totally see how you as an athletic trainer really move into the osteopathic.
That was the appeal for me, because when I first started, it was, working with team physicians, I got frustrated because I knew this stuff. I'm seeing these athletes day in and day out.
Right.
I know what's working, I know what's not working, and then I get frustrated when, basically you don't have any say as the athletic trainer, which is wrong. I think, we're allied health professionals. We have to take state and national board certification exams. We have to be licensed by the state. You don't have the capacity or the capability to prescribe medications, but sometimes that's a good thing,
right?
Because it forces you to use some other things. You use your brain, use some muscle physiology techniques, use some physical medicine techniques.
Yeah, you can't just throw a medicine at it, right? I can't just inject it. I got to be able.
That's what I hated about a lot of I had some great team physicians. Don't get me wrong, that were helping me along the way, but I hated that. Well, let's get a shot. Well, you need surgery. Like, well, no. I mean, now that guy is out. If he's got surgery, in some instances it's indicated. There's no going back. But now they're out. They're done.
Right.
And they may never be the same.
Right.
So that's what I got frustrated with. That's what forced me to try to find a better way to give myself that added edge. And of course, sports medicine was my ideal approach initially. Right. But as a good basic medical education program will provide you, it's a variety of settings. So I went into it with an open mind. Every rotation I was on was something new. It was terrific, but something kept pulling me back in towards the physical medicine aspects of things. Orthopedic surgery was somewhat appealing. I liked a lot of the people that I was around. We were cut from the same piece of cloth. Generally, they're very hard workers. They just get it done.
Right.
And that's another commonality with athletic trainers. They just get it done.
Right.
They don't say, well, that's not my job, because an athletic trainer has so many hats to wear.
Right.
It's in some instances you're the laundry guy, you're the equipment guy.
Yeah, I've talked
parent,
to
you're the shoulder to cry.
I talked to some athletic trainers who are athletic trainers at the high school, and at the high school, man, you're it. And we just talked with Webb earlier, and when he was telling me that his experience up at Temple in Philadelphia, he was the only athletic trainer for what seemed to be a million patients, and he's running around covering 500,000 sports, and he's trying to keep everything in order. And, it's one of those things that over the last decade or so, athletic training has really gotten some stabilization there, and is really,
which is good.
Yeah, moving up.
And
but it was a lot different when you and I were coming through. It was a lot different.
Right.
It sounds like you and I went on to some. I'll call it postgraduate work, whether you went on to medical school and I went on and got my doctorate. And we really went on for the same reasons, that, hey, I'm a little frustrated with where we are now.
Yeah.
And I think that the only way I can change it is go on and get this education and then come back.
Right.
And, pull my sleeves up and get dirty and let's go.
Right. Absolutely.
Okay, so you come out of osteopathic medical school. Now, we've talked to a couple other physicians, and again, we have some people that are listening to this radio show. Maybe it's some of my graduate students that are just getting into athletic training. And they're trying to think, okay, I've heard a number of different physicians. We had here sitting exactly where you are. We've had Walt Lowe, we've had Jim Muntz, we had Rahul Bajani, we had some other people that they're all in that kind of sports medicine umbrella, but they've taken these different routes. And so when you look at osteopathic medicine, a lot of the osteopaths go on and they go on to family medicine, they go on to, right? Rare that the osteopath, and the reason why I have so much admiration, one of my big mentors, Dr. Jerry Bornstein. Dr. Bornstein was an osteopath and orthopedic surgeon and old school. And back in the 60s, California passed a law where you could change your DO to an MD for $50. That's right. Yeah. So he changed from a DO to an MD, but he still uses all of his DO stuff.
Yeah.
So tell us a little bit about what's the difference in training between DO and MD, and tell us a little bit more about why you chose orthopedic surgery to stay in sports medicine, rather than, because it seemed like a DO in physical medicine and rehabilitation might be a good fit, or a DO in internal medicine or family medicine might be a good fit.
Yeah.
So tell us a little bit more about that.
Yeah, so the initial training, I think, in the difference between DO and MD just in medical school is there's not a lot of difference. We actually have a little bit more anatomy. I think the anatomy, at least from my experience with a couple of medical schools that I help teach at here in Houston, they cram it all into about a 3-month window.
Yeah.
We're doing anatomy for a year.
Right.
The first year, and it's just part of the curriculum, and then there's some neuroanatomy that's for about 3 months in your second year, and then in incorporation with that added emphasis of the human anatomy, you're also incorporating it's called osteopathic manipulative medicine, OMM, or it's got a, depending on
OMT or
something,
OMT,
exactly,
or MOMT, or
right. It's whatever alphabet soup acronym you want to use,
right.
But it's basically the same basic skills where you're learning how to evaluate a patient from a musculoskeletal standpoint, correlate a lot of these musculoskeletal findings perhaps with some not just physical complaints and ailments, but also some systemic problems. So you're really taking a different point of view and looking at the body, not just from what does the lab work show, what does the MRI show, what does the X-ray show, what are they acting and looking like, but from a standpoint of how is their body radiating or making this noise that you've got to pick up and listen to with your hands.
And I tell this story all the time when I teach the manual manipulative therapy in my rehab classes, that I walk into an athletic training room one day, and a quarterback is mid-thoracic, is really, he's just on fire. He's having trouble breathing. He's got that sharp stabbing, and they take him for an X-ray. Can't find anything. Take him for an MRI. They can't find anything.
Right.
And I do my evaluation. I said, he's got a rib head out.
Right.
What do you mean? What is that?
Right.
And I manipulate it back in, and that initial manipulation, the kid loses his breath, but then all of a sudden the pain's gone. And
you reset everything.
Right.
That's exactly
right. Okay, so it sounds like right off the bat, and I'm glad you brought up the thing about anatomy, because in order to get into the Master of Athletic Training program at the University of Houston, you already need a year of A&P, so A&P 1, A&P 2. You need biomechanics and exercise physiology and what we call anatomical kinesiology, like functional and motor learning. And then your first class that you take is an anatomy class with me that's a hybrid of functional anatomy and gross anatomy. We're working on cadavers.
Great.
So I'm going to extend the offer that over this summer, maybe we can put a scalp on your hand. You come on over.
I'd love that. I taught cadaver anatomy at Marietta College.
Oh,
yeah.
It's another commonality.
Yeah.
I taught cadaver anatomy too.
Yeah.
Okay, so you go through osteopathic school, and you come out in what year? You graduate when?
2003.
Okay, and so you graduate in 2003, and then you go on for a residency where?
At Toledo, Ohio, which was we had an affiliated hospital with Ohio University.
And is it an osteopathic hospital?
It is a general. We had MDs and DOs working side by side.
And when you're out of curiosity, because I look at the DOs similar to how I look at the ATs, right? Where there's some brand recognition, right?
Right.
And what's the in the AT PT world? There's always some turf battles. Is there some turf battles with the DO and the MDs or no?
It's less and less, and I think a lot of it's old thinking. There's and it depends. It's regionality too. In the Midwest, where there's a huge number of DO schools, people it kind of goes hand in hand. They know there's no difference. General public knows there's no difference. Down here in Houston, I think I'm, as an orthopedic surgeon, I'm one of maybe 3 or 4
in the state.
And just in Houston.
In Houston.
So there's a greater preponderance of them up north near University of North Texas, where the DO school is.
Right.
The DO schools, they pride themselves on primary care.
Right.
So family practice that you brought up, internal medicine, obstetrics, gynecology. I would also say orthopedic surgery is a primary care.
Right.
So, people are coming in to see you. You're the first guy they're seeing. They've got a, broken this or that, or a dislocated this or that. I mean, you could go to your family practice physician, and they should be able to know how to handle it. But the way medical education and training is going, they're throwing their hands up.
Yeah,
And they're
hey,
saying,
this is a referral.
over that guy. Exactly.
Yeah, this is a
So
referral.
I'd make that argument. And if as they also pride themselves on servicing the medically underserved.
Yeah.
So they'll be, find more DOs in a rural setting.
Right.
That's why, all of your initial schools were kind of, although Philadelphia's, eccentric, but Athens, Ohio, where
Right.
I went to school, it's in the middle of nowhere.
Right.
It's affiliated with a college town, Ohio University, big university, but you got to know, you got to be meaning to get there. It's not
Right.
something you just stumble on.
Right. It's not, yeah.
It's tucked
I mean, it's
away
like
in the hills.
when I took my electives in graduate school, I was at Long Beach State, and I took 6 hours of electives at the College of Osteopathic Medicine in Pomona. And,
Right.
to get to Pomona was a drive. And like
That's
you
right.
said, I had, you had to,
Right.
you had a reason to be there.
Right.
You weren't
But they're
just passing
servicing that community.
Right. Right.
And that's what they want. They want to basically outfit you to be able to be that front line, not to be reliant on a multitude of other specialists,
Okay.
A multitude of virtual anything you need from a diagnostic standpoint. We need the electronic doctor that's $1 million and we need it here. Like,
Right.
no, you're the person.
Yeah.
And you got to get it done. You
Yeah.
gotta make
It's your
that-
eyes and your ears and your brain.
That's right.
One thing I
Listen
always
with your hands.
Yeah, the one thing I always teach my students is, a lot of times, especially in the part of Louisiana that I was in, boy, I'd go to high school where this was the best medical care these kids were
Exactly
getting.
right.
Period.
That's
and, they didn't have the insurance to go get the MRI or the X-ray.
That's
So
right.
you know what? I am the MRI. I am
right.
the X-ray, and I've got to be able to communicate with a lot of these different people. Okay, so that gets us to you finish 4 years of osteopathic medical school. It's a 5-year residency program, and then you're a hand surgeon, so you've got to go on for a fellowship.
One more year.
One more year of hand fellowship.
Right.
And so where do you do that?
I did that at Baylor here in Houston.
Okay.
Yeah.
And then you talked about you're still hovering around that sports medicine, right? And so your background as an athletic trainer and as an osteopath. In your training, residency, fellowship, did you have any sports medicine rotations?
Yep. Everybody has, you've got some dedicated rotations in the different various areas of specialization. In the orthopedic surgery residency, you have to have, basically a certain, and it's a huge system of check boxes where you've got to be proficient at doing a lot of different things.
Right.
So for them to graduate you and say you're ready to be an orthopedic surgeon, this is something that this is where you're good at a lot of these. You're proficient. You may not be the world's foremost expert at them, but you can get it done.
Right. You're proficient. Right.
Right.
We have these clinical integration proficiencies in athletic training where we're going to go down and check boxes. Is
Right.
that really what they're doing is that can you meet the entry level qualifications of a
Right.
physician?
Right.
So let me ask you a question. You brought up a great subject, and one of the things that I always tell my students is if you don't know your anatomy, you don't know anything.
That's right.
So today we were talking about some lower extremity stuff, and I gave an example. If a patient presents to you with some pain in knee flexion and internal tibial rotation, it's what hamstring muscle are we talking about?
Right.
And they floundered around a little bit. It's semitendinosus, and this is why.
Right.
Right. So we talked about that. With your education, you just said that osteopaths they have a little bit more anatomy education in medical school. Did you feel like you were a little bit more prepared to go in your residency and fellowship because of that anatomy background?
Absolutely, and it kind of the unique feature of where I trained up in Toledo. There's a neighboring medical school in Toledo. At the time, it was called Medical College of Ohio. Now it's affiliated with the University of Toledo. But we would often share rotations with those other medical students from MCO at the time, and you feel like, well, I'm coming from a smaller program, not as well, well identified labeling that you bring up, and I felt like we could.
You're running circles around these guys.
Circles around these guys. We knew the anatomy. We knew how to apply it.
Right.
We knew what it meant.
Right.
And that was the key feature for me. you're building your foundation of your education. It's anatomy, it's physiology, and biochemistry. And then you can build your house any way you want. If that structure, that foundation is not stable,
Right.
if it's on sand and fog, good luck.
So one of the things I've always said in athletic training is that your foundation is anatomy, physiology, biomechanics, motor learning.
Right.
You know those 4 things, you can figure anything out.
That's
I don't
exactly
need.
right.
I don't really care about the names, but I know that the ACL prevents that tibia from sliding forward on a fixed femur. In order to test that, I need to take that tibia and pull it forward on that
Right.
fixed femur, and I've identified whether that's torn or not.
Mhm.
So you do your fellowship down here at Baylor College of Medicine,
Mhm.
and then what happens?
Then I took a job with, I was supposed to go back to Ohio
Mhm.
and work with the program that I trained at, but my wife said, you can go, but we're staying.
And when you
So,
say we, you're married and
yeah,
you've
I'm
got
married,
some
3
kids.
kids.
And how old are your kids?
17, 10, and 7. Boys
Wow.
17, just graduated from high school, and the girls are 10 and 7.
So going back when you were going through medical school,
He was 3. He started when we started. He was 3 years old.
yeah, how about
Yeah,
that?
that was a big jump because I left a stable, decent paying job.
Yeah.
I wasn't buying boats or anything, but we were
Right.
comfortable.
Right.
Had a great quality of life in Marietta, Ohio, and it was a big jump. It was one of those things. If I look back, and didn't want to say what if,
Uh-huh.
and I think we all have a path that's laid out for us,
Mhm.
and we just have to have the courage and the faith to take it,
To go get it.
to go get it. Yeah.
So it's another commonality that we have. When I finished my master's degree, my son was 3. My wife was 7.5 months pregnant with our daughter,
Wow.
and I drive from sunny Southern California to Hammond, America,
Uh-huh.
and I'm there for 10 years. And both my kids watch me graduate with my doctorate.
Uh-huh.
And I remember probably a lot like you, my kids looking at me, and if I think about it long enough, I'll start crying. But my kids look at me, and my dad looks and he says, "Wow, my dad's a doctor."
Mm-hmm.
And I thought, yeah, that's really cool, right? And probably
Yeah.
the same thing
Yeah,
for you.
my son was old enough to remember that. He was probably 5 when I was getting out, or no, 6 when I was getting out. And our daughter was born my internship year, so she was a little too young to remember that. But it's trial and tribulation, the
Yeah.
residency. It's one of those things I tell people now. I said every year is harder than the year before it. I always thought, well, I'll never be so busy, never be busier when I was a first year medical student. I go back to those days.
Great.
It was awesome. I was about 50 pounds lighter. I had all the time in the world.
Yeah, that's right.
comparatively now. So,
That's right.
yeah, but we did it together, and that's why I say, we went to medical school.
Right.
My wife, I was the sole provider. She had to go to work, and
That's
we
right.
had to address family care issues and child care issues, and
Boy,
it was a load. It was a rough road for everybody. But residency was tough. But you have to have good faith and a good family foundation and background, and otherwise you'll never make it.
yeah, and I remember I occupied our living room table for 2.5 years while I was writing my dissertation, and we couldn't have anybody over to eat. We couldn't have, because everything.
You knew where everything was.
I knew where everything was, and
Yeah.
I would at the time I was getting my doctorate. I'm program director for the athletic training program, and but I was also program director and clinical coordinator, and teaching full time, and I was still doing outreach for Jeff Schmidt over at North Oaks Hospital, and I'd do all that, and I'd write my dissertation. I'd sleep until maybe 2 o'clock in the morning. I'd write my dissertation from 2 to 4 or 2 to 5, and that's just how we did it, right? So
Chip
you'd
away.
go to medical school, you'd come back, and or maybe some of your other friends, they can go out and have a beer, but you're going home to your wife.
Yeah.
And you have a child.
Yeah.
And
It made me a better student,
right.
I thought, because I
Well,
wasn't
you got more
right
on the
out of-
line.
more on the line, and I wasn't interested in wheeling girls at the bars and saying, "Hey, I'm in medical
Yeah,
school."
that's right.
If I could do that. My wife's from Puerto Rico, but
Yeah.
if I did that, you'd find little pieces of me everywhere. You'd never see me again.
Right. So you come down to Baylor for your fellowship,
Mhm.
right? And boy, fellowship, you're kind of like you're the senior in the high school, right?
Yeah,
that's
that's
kind of
exactly
that's
right.
kind of the way it
Right.
is,
Yeah.
right? You're big man on campus.
Yeah.
But you still, and so you're doing your fellowship with at Baylor,
Mhm.
and who's directing that fellowship?
So at the time, it was Michael Epstein and David Netcher.
Uh-huh.
They were both my mentors, and then they had a host of other surgical staff, hand upper extremity specialists that we would also rotate with.
And then you get picked up by UT physicians.
Actually, I was at Baylor for 3 years.
Okay.
I joined the faculty there when my wife said, "You can go, but we're staying."
Yeah, that's right.
So divorce is out of the question. That's too expensive anyway. Right?
That's right.
And so, yeah, I have had a terrific opportunity at Ben Taub, which is the county hospital here. Heavy trauma. I was doing mostly.
Again, you're going to learn a lot, right?
Yeah,
you're thrown
absolutely.
into
the fire.
Yeah.
That's exactly right. So, and I was doing general orthopedic trauma, specializing in the upper extremity stuff. But I'm rebuilding knees and ankles and hips and pelvic stuff and all of that. It's just all that stuff.
And
just
at a
comes
county
rushing
hospital,
back.
you're going to see everything.
Everything, and it's the worst of the
uninsured
worst.
and underinsured.
That's
to,
right. These people that come up from Mexico,
Yeah.
they've already had something done, or they haven't had anything done, and they've had this fracture for 2 or 3 weeks, and now it's infected, or it's a disaster. And it sounds terrible, but poor people have the worst problems because they don't address them. They're complicated by other problems, diabetes, lack of care, and that bothers me. I'm proud to have said that I stood a post at Ben Taub. I still have I still go to LBJ, and that's an important part of my practice. I want to give that component back to the community because I never want to refuse care to somebody because of their inability to pay or whatever their insurance is.
My mentor, Dr. Bornstein, and I took this over from what he taught me on the clinical side to kind of this mantra that I developed in education, that the student is my customer, my product, and my asset.
That's right.
We're going to do everything again. But he always said, you really treat the patient first.
Right.
Worry about everything. And I think that's more of a DO type mentality. And what's really interesting about everything you're saying is that it really resonates really well with the athletic trainer. And so you're at Baylor, and then how do you get over to UT Physicians?
Grace of God and Walt Lowe reaching down in the ocean and saying, "Hey, I need, we've got an opportunity here.
So
I'd
he
like to
came
talk to you about
he found you.
Yeah, out of the blue. I didn't go looking to him. I was treading along, enjoying my time at Baylor. I wanted something a little more, and being at Ben Taub, you're kind of on a deserted island.
Sure.
And I had a little bit of a small private practice that I was doing through Baylor. Wasn't well supported, and I was getting frustrated with that. And I was at a point where I'm just going to dump the private part of it and stick with Ben Taub. And it's just the way things work out. Walt Lowe approached me and said, "I got an opportunity. I'd like to talk to you about it." I told him, "Yeah, I'm happy here," but then it got me thinking of some things, and I had asked Baylor to make some changes.
Walt does a really good job of making
He's
these
a good motivator.
Yeah, that's right.
He sure is. It prompted me to ask Baylor to make some changes, and they just flat out said no. And I went back to Dr. Lowe and I said, "I'm listening."
Yeah.
And here I am. So I've been here. It'll be 2 years in July.
Another commonality, right? I finished my doctorate, and I loved my time at Southeastern Louisiana University. It was a university where you're doing, you're wearing 10 different hats, and you're learning, right? And you're just in the trenches and the fire, and you're working and you're building. And so once I'm done with my doctorate, I go back to the administration at Southeastern. I said, "Hey, look, this is everything I've done. I want to try some new things." And they just weren't in a position to do it. It's not that, hey, we don't like you or whatever. It was just we just can't do it right now. And that prompted me to go look somewhere else. And just like you said, by the grace of God, Walt Lowe comes down and goes get you. Well,
absolutely.
My department chair, Chuck Lane, he reaches down and says, "Hey, we've got this opportunity for you." And as you and I were talking before, it's a Tier 1 university. I'm the director of the first athletic training program in Houston, and it's an entry-level master's degree in the 4th largest city in the country, and I get to work with, you and all these other places. And I'm happy to say that we signed an affiliation agreement with UT Physicians Department of Orthopedic Surgery. We also did with Memorial Hermann Medical Group, Memorial Hermann Sports Medicine Rehab, Memorial Hermann Ironman Sports Medicine Institute. So through all those collaborations, we're going to be able to work with you. And what I want to do is I want to extend an offer to you to say, I want you to come and I want you to talk to some of the students.
I love that. Yeah.
And it sounds like you would really just eat it up.
Yeah.
I'm sure if I put you in one of those, athletic training classes back again, man, I could
knock
just
out some of the old
that's right.
cobwebs, but I'd be right in, man. Yeah.
We'd just put some grease on some of the wheels and we'll get at it.
Yeah.
All right. And so, couple questions I've been asking a few people here. One is, and obviously you have a really unique perspective, right? Some of the physicians that I talk to, I ask, from a physician standpoint, what do you want some of those athletic trainers to know? Now, you're an athletic trainer. You're also a physician. You're also an orthopedic surgeon. So you have this really unique perspective. If you were to, talk to me as an athletic trainer educator, I have a way to kind of change some things.
Mm-hmm.
What are some of the things that you want me to know, that you want me to be able to teach these students that are more prepared to get back into that healthcare profession?
Yeah, I think you kind of already highlighted on some of the key issues. That's building the foundation as opposed to just learning how to what tool do I need to fix that. Mm-hmm. Getting away from the modalities, getting away from the hands-off components of it, where therapy is it's a very lucrative environment to get into, mm-hmm. but it's also very passive. Mm-hmm. You shouldn't be. There's some benefits to TENS units. I understand that, but that's not going to fix the problem.
Right.
So it's not. There's some benefits to ultrasound, but that's not going to fix the problem. So I think from my standpoint is knowing what the modalities do, knowing how to use them, but really getting away from them.
Really, just using them as an adjunct.
As an adjunct, exactly right. And for me, looking at all the other things as opposed and trying some of these other things. I just gave a talk in there about some of the hand and wrist injuries. And from my standpoint, what do you need to do first? Mm-hmm. Well, let's try those things first instead of like, you've got a wrist problem. I'm going to send you to this guy.
Right.
Like, well, you're an allied health professional.
Right.
You should be able to document accordingly and initiate a treatment plan.
These are everything I tried, and once I run into that roadblock,
that's
now
exactly
I go
right.
and refer out.
That's right. Now my hands are tied, or I'm at that point.
Right.
And then there's some other aspects where the higher up you get, it's the NFL, for instance, that stands for not for long.
Yeah, that's right.
And it's like, listen, I got to get a diagnosis. Is this guy going to be ready for Sunday or not?
Right.
I'm going to send you right to this guy.
Right.
The nice thing about that is then we can say, okay, this is it, initiate treatment program.
Right.
Okay, non-operative therapy, which is perfect. But at the periphery, high schools, community levels, they're the foot soldiers. They're the front line, and those are from my standpoint, that's what I would want out of the athletic trainer. A good assessment. We've already tried these things.
Right.
This is a chronic overuse injury.
Right.
This ain't working. And then having that element of the musculoskeletal therapy, the manipulative medicine treatment components, mm-hmm. those are safe. You don't have to take somebody's head to Cleveland and get an audible pop.
Right.
A lot of it is just muscle action.
Understanding the biomechanics of how they,
exactly
I did a demonstration today in class where I manipulated one of my students' necks, and it was just a little bit of distraction, slight,
it's gentle.
Yeah, slight.
You're not trying to kill somebody.
Yeah, lateral rotation. Movie, yeah, that's right. Slight lateral rotation, and they heard the audible, but he's like, wow, that's amazing.
Right.
Yeah, it's not high thrust, it's not high velocity.
No.
If you understand the biomechanics of how things move, you can almost fix anything.
That's exactly right.
What are some other things from an athletic training education side, right? So here I am as an athletic training educator, been on that route as you were too for a while, been doing this for 10 or 12 years, have this really unique opportunity to really change the face of athletic training here with this program. What's something that, as an athletic trainer, as a former athletic trainer educator, now as an orthopedic surgeon, what's something you want me to know?
That's a good question. I think from my standpoint is knowing you as an educator, knowing what I think from my standpoint as a physician that I would feel comfortable in letting those athletic trainers try and
mm-hmm.
teaching them some things.
Yeah, right.
It's not like, oh, well, you can't do that. Well, you're not a physician. You can teach some of this stuff to anybody.
Right.
And if it's applied in the appropriate setting, in the appropriate hands, not being afraid to think outside of the box of, well, these are the constraints that we have that we're not allowed to teach this.
Right.
And I would lean more towards being that type of an educator where, well, let's push the boundaries a little bit.
Yeah.
Now, not being ridiculous and pharmacology is important, but not trying to garner prescription writing,
right?
Because I think we do that too much in this country.
Yeah, I'm not going to put a scalpel in a kid's hand, but
right.
On the other hand, there's
knowing your limitations,
right.
Knowing what can you do safely in the proper setting with the proper training.
And now one of the faster growing fields in athletic training is this physician extender role.
Mm-hmm.
and that we see a model at Emory. And I've talked to Dr. Lowe a little bit about he's been approached a few times, and we're going to try to use this Master of Athletic Training program as a platform where, once my students come out of this program and they graduate, now they can go into a physician extender residency program.
Yeah.
And what do you think about that?
Yeah, I think it's awesome. Actually, a good friend of mine from LSU, Robert Bodier, he's a physician extender as an athletic trainer. I think somewhere down in Georgia.
Probably close to Emory.
Probably close to Emory. I don't know where he did his training. Very well may have been at Emory. And I just love the guy. And I thought, if you ever get tired of that guy, you come on over here, and I'll snatch you right up.
Yeah.
But I mean, it's those people. They've got that practical sense and that practical background.
Right.
And you've got hands on the job training, which is invaluable. Even I've just been graced with a physician assistant that I'm still trying to mold and shape a little bit.
And those PAs are really trained in more family medicine, general practice.
And just general practicing, because it's a month of this, a month of this, a month of this.
Whereas the athletic trainer has extensive orthopedic knowledge.
Exactly right. And if you take it into consideration, if you've got a baccalaureate degree, that's 4 years of training.
Right.
And then most people are going on for master's degrees or the additional extensive training or extended training. And that's you're coming in there, you've got a boatload of knowledge and hopefully some wisdom with all those years. And it's kind of hard when we're asking a PA to do certain things, and some of it's technique driven, some of it is just well, I don't really have any orthopedic surgery background at all.
Right.
You read their CVs, they're all very talented, they're very smart, very gifted, but they don't have any orthopedic surgery background. So I'm teaching them how to evaluate a wrist or an elbow or a shoulder. And
so if it's a general orthopedic, the athletic trainer walks in and does the apprehension test and comes back and tells you
exactly what it is.
Hey, look, here's what it is, here's what we're doing. And the two of you are able to consult a little bit, say, is this a surgical intervention or not? If it's not a surgical intervention, then you write a script right back to that athletic trainer, say we're going to do rehab, and it's all in-house.
It feeds itself, right?
Right.
That's exactly right. And it's not something, and at least where they're going. It's like you're referring a friend or a family member to somebody that's good.
Right.
And you can trust them, and they're going to get the job done right.
Well, I got to tell you, this has been an absolute great fun. You said before, I think that similar to you, I think we have some similar beliefs. When I was driving from Southern California to Louisiana, we want to take my son to the aquarium in Houston because we stayed here. And my wife looks it up online, and she finds this great place called the Aquarium at the Kemah Boardwalk. And it turns out it's not an aquarium; it's a restaurant called the Aquarium. But we go down there, and this is the most incredible time that we've ever had. And for the next 10 years, we talk about this experience for, probably a half a dozen times a year over 10 years. So 60, 70 times we talk about it. I get this opportunity in Houston, and the department chair picks me up, takes me out to dinner. Where do you think he takes me? Right to that exact place that we were 10 years ago. And I call my wife and I say, you'll never believe where I am.
Destiny,
and she says, where? And I said, I can touch the playground. This is where we are. She says, no way. They offer it to you. You got to take it. And you're right. This is destiny. So I think the fact that you and I are here together is one of those other examples of destiny. Well, again, thank you very much for everybody listening to the Sports Medicine Broadcast. I'm Dr. Josh Yellen with the University of Houston Master of Athletic Training Program, www.hhp.uh.edu/MAT. You can catch us on Twitter, U of HMAT. Catch us on the Sports Medicine Broadcast at PHS Sports Med or hashtag the SMB. And for Dr. Keplinger, thank you very much. This has been outstanding. I really appreciate it.
Thank you.
Bye.
Awesome. Thanks very much.
Yeah, so we're not that far much. A lot of very similar experiences. When I was an undergrad,
Because with some of our kids, like after a sprain on
I was thinking about that's reason you guys should do it, but so I have to see what the second word you and I had to give like touch and I was thinking, so maybe what you guys similar to I get like those I find out. So you're receiving
all these things that have gone through, say, like 10, 12 years. I mean, if you different really years. So that's not all. I'm not used to qualification. I see it. I can see this. They don't see it. You know, what's wrong with I can tell you, okay, you know, this is how you step versus some of that. It's getting other runners like this. I get a master's degree. That makes you more, that makes you, more attractive. By the time that 2 years was up, it was all PhD. Why am I still in school? And I started, when I was at Marietta, some politics with the department. We didn't have any PhDs. Paul Spear was the head of the department. So time spent that's exactly what we want. So RNs like training as well. Just a terrific guy. They were kind of cultivating and that's what it was me to try to take over that role as the chair. Because there was a guy who was a lot smarter than me and he knew he didn't want it. He had been there for about 10 or 15 years. It's $1,000 raise and $10,000. Exactly. Happy to be here. Up there at Marietta was, well, you've got to look at people. And what about that? We don't care as long as you have people. They just want to get insurance. That's all they care about. At the time, I was like background, the idea of having so the other avenue was I was trying to get into school. No, not at all. No, and I've got no sympathy for it whatsoever because to me it's I don't understand it. But this is I think anybody else.
So it's actually broadcasting live right now. So we haven't started the recordings yet. The recording is what I'll edit and post, but it's broadcasting live on YouTube. So everything since after lunch is one big block of interviews or recordings or stories or whatever. So this is actually a card. I don't know if you're interested in checking it out later, but so it originally started with my students, and I was just trying to figure out a way to record my lessons and put them on the website, and then it's changed as I've learned more. I developed
the whole broadcasting routine.
Yeah, and so we got this whole setup. Typically, I do it at the school with the students,
Sure.
and they're a big part of that. And you'll even see one of my former students interested in being an athletic trainer. She's the one running that end of it, and so it works out real well.
That's neat. That's great. That's good to do that.
You ready, Jasmine? Good? You ready?
Sure.
So I'll get it started, and Josh will join us in just a second. All right, so what's up, y'all? Welcome back to the Sports Medicine Broadcast. We are here with Dr. Blevins, and he's going to tell you a little bit about himself in just a second. But really good conversation that we had over there while Josh was still interviewing Dr. Keplinger was about ankle sprains, ankle bracing, and that kind of thing. And we'll talk about that here in just a minute. But Dr. Blevins, welcome to the Sports Medicine Broadcast. I'm saying your name correctly, right?
Yes.
Okay. So tell us a little bit about who you are and your practice.
Yeah, no, I'm an orthopedic surgeon that I'm with UT Physicians. My home and basically where my practice is in the Woodlands at the Hermann Sports Medicine Institute.
Gotcha.
And do standard stuff for orthopedic injuries and focus on sports medicine. I have a personal interest in foot and ankle surgery. I've done a fellowship in that, and that's kind of what we do.
All right. So you say a personal interest. Is that just because that's something that you had, or is that just that's your specific area?
So specifically for our group, we got several guys who do standard sports medicine issues as far as knees and shoulders, and I do mostly lower extremity knees, and then a lot of the foot and ankle that they don't do. So. Gotcha.
Okay. All right. Just make sure I understand the word.
No, sure.
All right. So I know we were talking over there, and since they couldn't hear it, I'm going to go ahead and say it again. Is one of the things that I'll often do, since we have extra walking boots, is after a kid sprains an ankle, even if it's not really bad, I'll put them in that walking boot for about 2 or 3 days, that kind of thing, and let them calm down, and that way they're not so inflamed, they're not trying to walk on it or limp on it. And then reevaluate and begin exercises. Even we'll begin exercises the next day, range of motion exercises.
Right.
So what are your thoughts on that?
Well, as you were kind of describing to me, I was talking about how it really is a good idea, because what I try to do with folks, at least when we can get that initial assessment, as we were discussing in the talk, I mean, it's very difficult in the acute setting to get the right understanding of how to categorize some of these injuries. So sometimes they all seem severe, or they seemed minor and then they turn out to be more severe, that you kind of want to be protective early on. And I think what I found is if you can get folks to a ambulatory status, which the boot would provide, rather than having a lot of motion with some of these ankle injuries, it's very helpful. So, if you put them into a functional, lace-up brace or something like a stirrup brace, there's really not that protective immobilization that will allow them to be weight-bearing. So they may try it, and they're still very painful. They're still using crutches. They're really not mobile. And so if you can still protect them, as in like you're truly immobilizing them, and then reassessing them early, I think is kind of the key, because what we find often is within 2 days, I mean, some of these folks look so much better that you're very surprised that it seems so severe to start with.
Right.
And often the other way around, you get the reassessment process going, you realize, wow, this is a much more severe injury than we initially thought. So it gives you an opportunity to both manage, support, move along, and then make a decision later about what's the right thing in the early phase.
All right, very cool. And then the other thing I was telling, we were just talking about bracing with the immobilization. So taping, one of the things I got from, again, I mentioned his name because I got it from a guy on Twitter, is S. Lorio, but I don't even know his name because that's what it says on. Do you use Twitter?
Not much, but yes.
All right. So, anyways, that's what his name is. And what he does is anybody that wants to get taped, they have to do proprioceptive exercises.
Right.
So like TheraBand exercises, balancing exercises, I think single leg squats, those kind of things to help strengthen the proprioception of the ankle before taping. And so what are your thoughts there on that?
Well, yes, I think most definitely. I think if that's the carrot that you dangle to get some of these folks to do the appropriate exercises and proprioceptive training, that really does help prevent these type of injuries. It's worth it. Taping we know as a thing that we can do for folks. It can be helpful for some of the feedback it provides. Very often, though, it loosens and then it's no longer doing what it was initially designed to do after so many minutes of activity. But still, I think getting folks to do the proper preventative training is probably helpful. And that's been shown to be very effective if you can do it.
All right, so jumping around a little bit, in your talk, you were talking about diastasis, being a high ankle sprain. I don't actually know what that word means.
Yeah, so diastasis means widening. So if at the distal articulation between the fibula and the tibia, if where that normally ligament crosses and provides that stability at that level, with that being disrupted, there's widening. And we term that diastasis. And so that's an important finding on x-ray, because if that's true, you know that not only is the ligament injured, it's completely disrupted and can cause a lot of instability. And those folks, because that is pretty much the corner of the ceiling of your ankle joint, it's really important to maintain that configuration. So when that's disrupted, that's more of a surgical management to restore that.
All right, so we actually had 2 girls this year. Both of them in volleyball have a high ankle sprain, and the orthopedic surgeon, Dr. Crumby, I was there on the Saturday injury clinic, and he recommended surgery for one of them, but she was living with a friend, like no insurance, that kind of thing.
Right.
Ended up not having it, and then came back to play like sporadically, just because she's like she would play and then it would be hurting.
Right.
So what do you think of the long term? How's that girl going to fare? I know you didn't see it, so you can't,
Well, sure. I think, the issue with the high ankle sprains is how much of an injury is it, and sometimes it's difficult to gauge. I think we do see some of those folks do extremely well still. Their treatment is a little more prolonged as far as recovery, but still can do well. And I think it's a judgment call, and it's a little controversial on which ones are bad enough to treat surgically and to restore that stability. I think if you truly have widening that you can identify on even plain radiographs or standing x-rays at least, some of those folks definitely can benefit from it, because every step they're taking, there's that splaying effect of the two bones coming apart, and that's not natural or normal or
Right.
for normal healing. So in essence, some of those folks, even though you'd say, well, who really needs to be fixed? Well, those if you fix, may recover much quicker. I mean, so that's definitely a judgment call, but definitely something we entertain.
Yeah, because he was saying that she's going to have chronic ankle instability or chronic
That's right,
pain.
and that's what you worry about. And those are the ones that I said, it's a feel of who really needs it, and some of them do not do well from that standpoint of they just have chronic ankle issues. And in my talk also, I was commenting on how nearly a third of all chronic issues, as far as sports injuries go, are the ankle. I mean, it's pretty significant that if we don't, identify these things correctly and have the proper treatments in place, they become chronic issues that are difficult to manage.
Yeah, I've been learning more and more. I mean, I've been doing this podcast for, I don't know, about 3 years now, and it's amazing how much I learn just from talking to people, because sitting in the lectures is one thing, but then I get to ask you questions.
Sure.
You get to explain it to me.
Sure.
And if I don't understand it, then I say, hold up, like diastasis. I didn't know what that was. Widening. Oh, well, that's easy. I get it now. Now the whole slide makes sense.
Right.
So,
sure.
Now you also mentioned the screws breaking off. How often when you're fixing the what is it?
Yeah, so the syndesmosis there.
Yeah.
So normally what we do, if you have a bad enough widening in the diastasis there, it usually requires 2 to get some true control through that zone. And so we usually put those several centimeters apart, because one would just have kind of a toggle windshield wipering effect that we don't really want. So usually do 2, and usually in those cases, actually, the chance of it breaking are not very good, because there's enough kind of bridging support for each one. However, it can happen. So if you let these folks bear weight and become more active with that rigid construct there, when there's supposed to be some motion and translation between these two bones, it's at high risk for breakage, just because it's so rigid. And so typically we remove them. So when we get people far enough along that we think the recovery is good and the ligaments are healed, we'll actually plan to remove them, and then obviously you don't worry about the breakage beyond that. So the key is getting to it early enough and knowing that, yes, it requires an additional surgery, but a pretty minor thing. And most of them, it's an improvement, because now they've gained that motion back that was fairly fixed, and they're happy with that in that phase.
You said that removement is normally 12 to 16 weeks. Is that what I heard?
Yeah, so typically, ligaments take a little bit longer to heal than bone sometimes. So we're expecting ligaments to heal usually within that 12-week period. So if you can go ahead and plan on removing them when you know they're healed, that's kind of the move.
Right. Were you jumping in here? Or you?
No.
Okay.
You want me to?
Sure. I just figured you would.
Hey, what up?
Sure, why not? You know Dr. Josh Yellen?
Hi.
Hey, Josh, how are you?
Hi. Josh Allen. Nice to
Levins,
meet
good to see you.
Yeah, I'm jumping at the last minute here.
So he was talking about ankle sprains, all the many different ones, and we were just talking about high ankle sprains and
Oh, and the
those kind of
syndesmotic
things.
joint, the anterior tibiofibular ligament, always really hard to heal and to treat.
No question. I said the difficulties with knowing who's got the bad enough injury to fix, and those issues are difficult sometimes.
Yeah. So can you elaborate, just from my own knowledge, right? And as an athletic trainer, we have a high ankle sprain, that syndesmotic joint, the anterior tib fib, and it's usually either that forced dorsiflexion or that forced plantar flexion or whatever it is. And so go from a surgical standpoint, when do I refer?
Well, usually the decision maker is understanding the mechanism usually and how severe it is, because that forced external rotation or forced dorsiflexion is what gets you a syndesmosis injury. So usually in those instances, from almost on exam or that reassessment time we were talking about several days after the initial injury, how severe some of these are, and can bear weight. These people are not doing well.
And it's the Kliger test or the Kliger test that you use, right?
Sure. So doing some of these squeeze tests and even just on palpation up the syndesmosis and the interosseous membrane, knowing how high the level of the energy goes is helpful. And then standing plain films are very helpful, just to see is there truly a widening of the syndesmosis. Is there gapping on the medial aspect of the talus where it can indicate that the deltoid has been disrupted or injured as well?
And what would you see if I take a plain film, and I'm assuming it would be an anterior posterior or something, right?
Mhm.
And on a simple film, I would see that the black hole of gapping. What would I
But
see?
sometimes on just a plain standard film you would, non-weight bearing. However, sometimes you can appreciate that nuance by getting a standard film and then a standing AP film, because you can really demonstrate, wow, look how the talus translates laterally, that you get that external rotation force that's created just by weight bearing.
And that's indicative of, obviously, that deltoid ligament is
That's right. So, and the deltoid is it's interesting enough, be having the superficial and the deep fibers. There'll be times some of them are disrupted and some are completely intact depending on the foot position.
Right. So
you can be fooled on exam whether they're all intact. Rarely are they all gone, unless it's just severe, and that's usually very obvious. And so what happens is you will see the translation, but some tethering, but it definitely is a gapping. I mean, you will appreciate that on plain X-ray sometimes. And those just really indicate the severity of it. So then you're looking at overall, okay, that truly is this disruption, and the continuity of the joint is disrupted like that. I mean, you really got to be concerned about what is the long-term healing prospects in that alignment, which is not desirable.
What's your experience with that? So, let's say I have a patient that goes into that forced dorsiflexion, forced eversion, right? I really put some stress on that deltoid ligament, that elusive deltoid ligament, right?
Right.
And I do the Klieger test or the Kliger test, depending on what part of the country you came from. And I'm treating kind of conservatively, and maybe I put I refer to you, I put him in a walking boot.
Right.
And we're gonna watch, and we're gonna watch, and we're gonna watch. At some point, we got to be able to say, okay, this is a surgical intervention or it's not.
That's right. And I think that's sometimes a tough call. Usually you get these folks, that 2 to 4 week period of not seeing a progression is pretty helpful to know. I mean, you kind of know within a month they're just not getting better. Now, the key is knowing what the progression has been, or lack of, or what it is, because some of these folks, I really will, knowing how, the potential ramifications of missing it or not knowing how severe it is early, will really protect them to get them to a stage that then I can test them out functionally and know where they are, and then you have a better feel. But it's usually about a month.
Now let me go back to something on clinical exam, right? So if I go down my anatomy, I've got that medial malleolus, and then obviously I've got the talus, and I go just a little bit medial, and I've got the navicular. On a clinical exam, somebody that's just coming out of school,
right?
They may say that they may see the drop in the navicular, and they may say, oh, that's really
right.
That's a pronated talus. It may not be a pronated talus. So walk us through that a little bit.
So sometimes, I mean, even knowing really clinical exam as far as palpation is difficult because things are so close in proximity that sometimes you get a misread on what that really is. I think it's putting it all together as far as knowing some of this diagnostic imaging that's helpful, knowing an exam, knowing the progression on repeat exam. I mean, those are things that really put it all together. It's hard to know. With the deltoid ligaments, interesting enough, they do extremely well, even with severe injuries. It's
a strong complex.
It is. And so what happens is it's also got the potential for healing because of all the surface area. So you've got all this other potential area to come together. And so what happens is, very commonly we'll have patients with a lateral malleolus ankle fracture that will fix, concerned about what the deltoid, because we know there's this lateral translation that we can see of the talus shifting and the deltoid being injured, and they do great. And we never touch, open, even think about fixing the deltoid because historically we have not been able to make a difference in that. We haven't made it better. It's kind of been what it is, and it is interesting enough. Some of those folks they have more pain from that for an extended period of time than they do from their fracture after the fixation. So it's something to make people aware of, counsel, understand. It will get better. It just takes time. But those are not we're not as aggressive with management. That just given the history has been that they do well conservatively.
That's great. I don't have a whole lot of other questions.
Sorry, no either. We're good.
Let's go to the lateral side of the ankle. So, I've got the trifecta, right? I've got the anterior tibial or talofibular, calcaneofibular, posterior talar fibula. All right, anterior talar fibula, 95% of all ankle sprains.
Yeah, it's bad.
Yeah.
It's very common.
Anterior talar fibula.
Very wimpy.
Straight anterior drawer, right? And it's just, if I look in my mind, I've got this tiny little, it almost looks like a piece, like a towel, small towel. It connects, from fibula to talus.
Right.
Anterior drawer, I pull it forward. It's just loose. Okay. I can also do the talar tilt. I can also use talar tilt for eversion.
Right.
Right. Okay.
Right.
So tell us about grade 2, from a clinical standpoint, patient presents and it's, I went in that traditional kind of plantar flexion, internal rotation, supination. I got this part. You take your 10-pound thumb, you press right where that ligament is,
right.
Jumps off the table. You already know what it is.
Right.
So walk us through between progression of, ATF to CF. And then when does that posterior involvement start to happen? And what should we look for?
Exactly. It's more with the all of them kind of start in a similar mechanism, and then it's the completion of that mechanism or how far it goes.
Okay.
And so usually there's more of a rotatory component to it that can be more significant to develop the injury that continues all the way around. The direct, inversion is really how you injure your calcaneofibular ligament.
Right. No real supination.
Not necessarily.
It's
so
just a
because
straight.
it's fairly loose in a plantar flexed kind of supinate position. So usually you have to have a significant inversion as well. And then that rotation that cuts from the supination zone is what finishes off the posterior.
Right.
So then those can even come full circle. Then we're talking about how much it disrupts the deltoid ligament.
Really?
Yes.
So,
and so
because of
with
that
injury,
extreme supination and inversion, right? It kind of pinches that medial malleolus, and now
that's
you
right.
Start
so
to
now you start getting that. So it is interesting, the progression, and it's just hard to seeing it. Sometimes you've got to say, oh man, this is going to go a certain way. It really just depends on how people react to that as far as when it happens. I think the key is. And it's funny grading them because obviously, a type 2 or even a type 3 anterior talar fibular ligament is are going to do much for that. You really don't have to.
Right.
Even those can be severe grading, but actually not a very bad ankle sprain.
Right. I mean, you're going to see some capsular swelling. You're going to see your basic effusion and maybe some edema, some exudate, but with some elevation, ice, and compression.
They do extremely well. So you get a combination of significant, and to get a significant, usually a calcaneofibular ligament injury, there's some component of the talar just because of just the location wise, and so in the translation, so there's enough translation used of the talus to develop that injury that you get an anterior talar fibular ligament as well, and that combination of what can be bad. Okay. That definitely you will end up seeing these folks that truly, just with some gravity, have a little bit of a talar tilt, and an exam, they literally, you can just kind of keep coming.
Yeah,
and
it's
really
like that torn ACL.
It's right.
It really does. Move that tibia from here to Ohio. And
that's right. It keeps coming, and even some are even the talking about looking at these where you can see the deltoid is still intact, and you'll see a pivoting.
Really?
Where you can almost grab the whole hind foot and pivot around the deltoid.
Really?
Yeah. So it's a severe enough injury that if you can get the nuances of that on exam, it's pretty significant. And so the key is usually identifying that enough to know, okay, these are the folks that we need to be very aggressive with, conservatively, to know that they're not going to develop a chronic issue,
right?
And then or re-injury, at least in the early phase of the appropriate management.
Okay, so now let's go back to we got the ATF, we got the CF. Let's go to the posterior talar fibular ligament.
Okay,
you're right, and I'm assuming that is again, going back to, not necessarily the it's just straight inversion, really.
Yeah, so exactly.
And
so
you said the completion, right?
Yeah,
it's going around the clock.
So if you can imagine both the calcaneofibular ligament as well as the posterior talar fibular, because of the location and where they attach on the heel more posteriorly, it's a dorsiflexion actually puts them in more stress.
So if I have a dorsiflex situation, an inversion. So if I have a forced dorsiflexion
and an inversion,
I'm going to go CF, PTF.
Yeah, no question.
And if I have forced dorsiflex and eversion, I got deltoid. So really,
you can have
plantar flexion is really that anterior talar.
That's right, and you think about it. The benefit of the plantar flex position, or at least benefit, at least from an injury standpoint, is there's some laxity based on the structure of the talus. Being wider anteriorly than posteriorly, when the anterior portion is not engaged, there's a lot more play and laxity in the sense that you can easily injure your ligament, but as far as local damage that's not that significant.
So and it's really interesting from an athletic training standpoint, right? When we're going to go tape an ankle, what are we always taught? We're always taught, put them into dorsiflexion, kind of close the
right, exactly.
Close
That's the
that
most stable
talus.
position.
Right, close the talus in there and tape them in that situation.
That's right.
All right, let's go to in my history of practicing, I've seen all these sprains that you're talking about, all the injuries. I've never seen a posterior tibiofibular
Right.
ligament.
Yeah.
How does that happen?
I don't think you can get it in an isolated way. I mean, I think it's more of a true structure that we can identify, anatomically and say, hey, this is in the constellation of ligaments that we've got in this zone and how they're injured. I mean, they do all sorts of interesting studies looking at the strength of it as they fractionally release them and do that kind of study, but I think as a unit is most isolated.
And so let's just say, hypothetically, I release the posterior tibiofibular.
Mm-hmm.
What happens?
Probably not much.
Yeah, that's right.
I mean, honestly, it's and these work in concert in certain positions. I mean, you may be able to injure things.
Like all the posterior musculature that's back there.
That's right. I mean, it's well protected. There's no question.
You got at least the soleus, right? If I depending on where you came out, you got your anatomy, right? If I think of triceps suri, I've got plantaris, soleus, gastrocnemius. If I go kind of out of that European triceps suri, then I've got soleus and gastrocnemius, and I think only 35% of the people have got a plantaris or something like that.
It's not behind.
And the best way to identify is that whether you've got a palmaris longus. Is that right? Is that a true?
I don't know. I don't remember exactly if that's indicative of that, but
it's one of those tertiary muscles.
Yeah, I got one.
It's like the peroneus tertius. I mean, it's
right. Yeah, it's vestigial. You don't
really need
it. That's right.
Okay, so when I think about that posterior aspect of the tibia, I've got those big, plantar flexors that are back there that are really providing a lot of.
That's right.
Right, and I've got some retinaculums around there and some fascia. And
I think the idea is, if you think about it, I mean, although it resists force in a dorsiflex position, I think there's so much other stability created in that position that your chance of injuring it are almost impossible. I mean, you're going to end up doing something else significant, and that's going to be irrelevant as far as how significant that injury is. Yeah.
All right, so now let's kind of go back to, let's keep on working posteriorly. Tell me about ruptured Achilles tendon.
Okay.
All right. So I was taught in school, right, you've got that musculotendinous junction down to the osteotendinous junction. Somewhere between the ages of 40 to 50, that osteotendinous junction starts to change from a biomechanical standpoint, right? And they put on that kind of forced dorsiflexion, right? And they feel like someone kicked them in the back of the leg.
So it's the eccentric load.
Right.
That's significant. So you're both contracting the muscle at the same time it's elongating.
Right.
And that's a significant increased force on that structure. And so, yes, what is the big deal? It is significantly an issue in those who are the 40 to 50-year-old males.
Why?
It's an anatomic,
it's an anomaly.
Developmental issue as far as aging, I think, that puts you at risk. And yes, they said the same thing. They want to know who hit him with the bat,
Felt
or
like
who shot
me
them.
in the back of the leg.
I mean, and Kobe Bryant said the same thing. I forgot who was guarding him when he ruptured his. He turned around and asked him why he kicked him. The guy looked at him like, "What are you talking about? You just fell down."
Yeah, that's right.
Yeah, so it's very common as far as the way it feels.
And it's more common to rupture, in school, right, you learn about these different avulsion fractures. And so when Achilles ruptures like that, is going to take a piece of that periosteum off with it?
No, typically it's a little more proximal.
Yeah.
So most of these are happening in the true tendinous portion. Is there some people prone to this as far as having some degree of degeneration or unhealthy tendon in that zone? I think that's probably true. We do see some folks who have what we would term a prodromal syndrome of something. They'll say, my ankle was hurting for the last 3 weeks, and then I went and played basketball, and the thing snapped.
And I had this force eccentric load. And
they'll say that. They'll finally say, it's almost like I could tell something was going to happen. It just wasn't feeling right. Now, they didn't expect that, but it's pretty significant that some will tell you those stories. So,
and then, once that calcaneus or once that Achilles tendon rupture, they can. Now they can't go in. They can't essentially. They're bipedal mammals, so now you can't.
Well, this is what happens. So no question. I mean, your Achilles is basically a very controlling stabilizer muscle complex. Most of your plantar flexion, as far as push off, is really your posterior tibialis. So these people, some people, think something's wrong and they can still ambulate. Some can't. It's interesting how they do. I think it's important to restore that normal function as how those interact, because it's very dangerous to not have that protective, decelerating position that the Achilles provides. But it is interesting to see how some people do okay without it, but definitely not athletically.
Yeah, I mean you can't go Achilles tendon deficient.
No, it's very hard. I mean, the very few folks do we allow that to happen in.
And what's the situation? I'm assuming geriatric population.
Yeah, that would be it. I mean, I think we do have some folks who may not be best candidate for surgical treatment and can treat conservatively. There's some that really are proponents of that management. I think the key is treating them appropriately in that fashion, where you have to get the some degree of apposition of the tissue to get proper healing.
Okay.
And have the mechanical advantage. The problem with that is just how do you do that? And so typically it's serial casting, deep plantar flexion, then you bring them up serially with casting. And it does work. Those folks are a little higher risk for re-rupture because of the scar, the tissue that becomes interposed in there. And you usually have a little bit of less power for push-off. But I mean, some of them, you'd be hard-pressed to say, hey, you didn't have this great repair, right? Because they didn't, and they do fine. So.
All right, so now let's move anterior a little bit. You have some people that are listening to this broadcast that either are a lot like Jasmine, whether they're just coming out of, she's in her third year at Texas A&M. So we have this, vast array of people listening. Let's move forward now. Let's talk about a Lisfranc fracture.
Okay.
Go. What's a Lisfranc fracture?
Lisfranc fracture is usually some version of an injury that happens involving the Lisfranc ligament. And
which is what?
Lisfranc ligament moves basically from the medial cuneiform bone in the midfoot, traverses towards the basically the base of the second metatarsal, and what that provides is what we call the Roman arch of the foot. So it is the actually not longitudinal arch support, but it's the cross-sectional kind of side to side, so medial lateral support, and it's critical really attaching the first ray to the rest of the foot.
And the first ray for those is also the great toe.
Yes, sir. So the great toe side of the foot.
Right.
And we call that the ray, meaning all the way up. So from the actual toe through the metatarsal into the midfoot zone. And it's really critical for maintaining that Roman arch that we talk about, and how these medial to lateral bones are kind of stacked in the Roman arch. And so when that ligament is disrupted or injured, very commonly it'll actually it's strong enough and thick enough that it'll actually pull off a fragment of bone.
An avulsion.
An avulsion fracture that we would term, a Lisfranc fracture.
And so how does somebody happen, right? I remember in graduate school, it was the first time that I had seen a Lisfranc fracture. I thought, that's really interesting. I don't even know what that is. And then, we had a foot and ankle specialist say, this is what it is. So what happens? How does somebody get a Lisfranc fracture?
Well, usually it is a loaded plantar flex foot.
Okay.
So and so we see this very commonly, linemen, people stepping off a large step onto their forefoot, and basically kind of the crumpling phenomenon of having so much force quickly generated on the midfoot that's not ready for that.
And so you say forced plantar flexion, just to give everybody that's listening a visual, what does that look like?
Yeah, so kind of pointing your toes and stepping very hard onto your forefoot.
Right, and all that force being translated in your forefoot.
That's right. So sometimes it's enough of your own body weight to be enough if it's transmitted the right way, and we see it a lot of times in linemen or people who are injured when someone else steps on the back of their foot with their foot in that position.
Right, and that's a if I think of it correctly, right now you're in a truly forced.
Yes, I mean that truly is a forced plantar flexion.
And so if I kind of move up a little bit, just to give everybody, so we've talked about Lisfranc, Achilles tendon, all the ligaments of the ankle, essentially what we see clinically. Let's move up to this grand term of what we call shin splints. Right, shin splints, in my definition, is a catch-all term to anything happens in the lower, shank.
Right.
essentially.
Yeah, right.
Tell us what you think.
Yeah, so I mean, typically it does come a little bit different. I mean, it is kind of a catch-all terminology. Most of what we see is either some version of what we call periostitis, where these folks develop the periosteum becoming very inflamed in that anterior distal third medial aspect of their shin.
On the tibial side.
On the tibia, right. So that happens commonly. It truly being a inflammation of the covering of the bone. In others, it's more of a irritation as the muscular, the flexors of the foot, actually the muscles come off of that zone and the bone. And so, and depending on how you figure out which is it the muscular pulling that's causing the inflammatory process? Is it just something happening in the muscle? It's debated, but that's the area.
So a lot of people, when they point to shin splints, really, that kind of term, they're really kind of pressing on that tibialis anterior, but they're not. It's not really the tibialis anterior. It's
No,
or it's the periosteum.
Yeah, exactly. So most of the time, it's just posterior to that ridge that really gets you more into the posterior muscles. And sometimes, it's a little more anterior just because of the way the tibia is so accessible to find anteriorly, and you can push there. And if you push on your shin right now, I mean, that's a tender area regardless. I mean, even with my normal shin, I push on it, I'm like, ow, that's uncomfortable, right? So I think it's highly sensitive.
Yeah.
So I think some people maybe are more sensitive than others, and that would develop it and say they have it, and you'd say, oh, that's no big deal, I'm fine. So, but it does happen, and people get enough of irritation that prevents them from being able to be athletic and active.
I want to stay on the talocrural joint just for a second.
Okay.
And let's go into. I remember when I first saw the abbreviation, I thought the ankles got obsessive compulsive disorder, and then I thought it was the organized crime division, and it's
right,
not
exactly.
either of those. It's osteochondritis dissecans. So
right.
Explain to us a little bit how this joint mice happens.
Yeah. So some folks just either genetically or congenitally or whatever you want to term it, have a area of their talus that at the level of the ankle that develops this lack of full normal bony structure. And what happens is in those areas, it's almost like a pocket beneath the cartilage cap that's covering the talus. And so structurally, it is not sound. And so very commonly, these folks will not have any problems for years and then eventually develop enough of either erosion or irritation or something to that zone and develop a tear of that cartilage. Because it's kind of like a trap door. It just kind of falls into the space. Or in some ways that the bone that's involved that's not healthy becomes dislodged with a piece of or fragment of the cartilage, and then you can get joint mice and different things.
Yeah, I remember when I was a graduate student, I took one of the athletes over and we took a picture of it and said, oh, we put it up and said, you got some joint mice.
Right.
And he looked at me and he says, man, I got a mouse in my ankle. And I said, no.
Exactly. Right.
That term. Why do they call it joint mice?
Yeah, that's a good question. I'm not sure I know.
You don't know, you just know it is.
And that is what, commonly referred to as joint mice.
Yeah. And we also see it in the elbow.
We see it other places too. It's not uncommon. Our body and definitely the joints tends to almost act as a pearl sometimes, that you'll have an irritation of some sort that is kind of like the seed that will then become calcified in this buildup and develop into more of the joint mass situation. So you see that sometimes as these calcifications.
And so if I move up just a little bit, right, we talked about shin splints, and we kind of go up and down here a little bit. Tell us just real briefly, and then I think I know you're busy, you got to get going here, but tell us real briefly about the difference between acute and I guess it would be chronic, and the term just escapes me now, but that compartment syndrome. When I was in school, I learned, hey, look, you can get kicked, and you've got this acute, chronic compartment syndrome. But then you've got this chronic, where it's kind of like the shin splint. Those capsules are, collapsing on.
So the difference in those, I mean, obviously, with an acute compartment syndrome, we see that mostly with an injury or something that would give you this all of a sudden dramatic change in either the a swelling in a confined compartment. And we talk about these compartments. What we're terming that is really these muscles that are trapped beneath the fascial covering that divides them into different compartments. And so if there's enough swelling or increased pressure that develops because of that swelling within those compartments, you can develop damage to the actual muscle and be permanent. So acutely, that's important in tibia fractures, things that have a lot of trauma can be concerning. Otherwise, for the chronic versions that people develop, it's more exertional compartment syndrome is what we would term that. And so those folks are developing increased swelling by using those muscles with running different activities, and they'll present with just leg pain. I mean,
Right.
and it's a transient phenomenon that will happen. They're fine with the activity. Then they wait, and 20 minutes later, after they're finished running, their leg is really hurting severely, and then it dissipates over the next hour or so.
And anybody that is familiar with that lower leg anatomy, right? We always go back to the Tom, Dick, and very nervous Harry.
Right.
Right. Jasmine, have you learned about that? Tibialis posterior, flexor digitorum longus, tibial artery, tibial vein.
Very nervous here.
Yeah, I mean, hello.
What's your house is like?
Yeah.
That's right.
Yeah. Well, I appreciate your time, and Jeremy, thanks for throwing me in here at the last minute.
Sure thing.
I appreciate it. You want to sign off? Go ahead.
Well, for the sports medicine broadcast, we got one final interview with Dr. Bryan. He's going to jump on here in just a second. But for Jeremy, Dr. Yellen, Dr. Blevin, with the ankle injuries, a foot and ankle specialist, that's a wrap.
Thanks.
Great. Thanks for having me.
Thanks a lot.
Thank you.
Thanks for coming in.
Enjoy it. Yeah, it's good. Get it down.
Yeah, I'm glad. Where I ran over to, so I'm the director of the
10 minutes. Okay, great.
And so,
If you come right here, Dr. Bryan.
Yeah.
Bill will watch the time. Keep it to 10 minutes.
All right.
Obrein. IEN. I'm terrible at spelling.
That's
Terrible.
No problem. I got one of those names that gets misspelled all the time. So what is this for? Just kind of a wrap up of the meeting and.
Yeah, this is actually this is the sports medicine broadcast.
Okay.
So what typically I do is I'll bring speakers to my school and they'll
Okay.
talk to the students, and then the podcast is edited, published on the sportsmedicinebroadcast.com, and then that's used for athletic trainers to download anywhere to earn CEUs,
Oh,
any
cool.
BOC CEUs.
It's a great idea. How
And
long have you
so-
been doing that?
I've been doing this for about 3 years, and then it's really blossomed this last year since we met Dr. Yellen and Knobloch, and then obviously Bob Marley allowed us to come here today, and while all the experts are here, might as well just shuttle them in here for a few minutes. And so what we'll end up doing is taking the talk that you had in there and then put this on the end of it.
Okay.
And so
Cool.
all right, so I know one of the questions that somebody asked at the end there was about having a team dentist.
Right.
We had spoken with a dentist earlier this year, but I really want to know, because I honestly have no idea who to call if we have a dental emergency.
Right. Well, basically, there's a society called the Academy of Sports Dentistry. As a matter of fact, we're having our annual meeting in San Diego next week. We get together once a year and we compare notes, and not everybody at the meeting is affiliated with a professional team or a college team. Most of them are affiliated with high school teams because there are a lot more high schools than there are colleges and professional teams. But they have a team dentist course that you literally take. And obviously they don't teach us how to do dentistry, but they just teach us the protocols, things as simple as how to set up physicals for when you do physicals, how to set it up for the training room, and taking impressions for mouthpieces, doing screenings, that type of thing. And but the Academy of Sports Dentistry has a list of, I think there are now about a half a dozen people in the area of Houston now that are members of the Academy. I was the first, but there are about a half dozen people or so now, maybe more, that are, and I'll find that out next week, that are actually members of the Academy and are trained and have taken the team dentist course. You do not have to take a team dentist course to be a team dentist.
Okay.
You just basically have to be a dentist, and most dentists are versed very well in traumatic injuries and how to handle them. Unfortunately, most of them have not seen them since dental school because they don't work in that type of an area. I've been blessed, and I work in an area where I see traumatic injuries all the time, be it on the professional or college or high school level. I see more from the college level than I do from the professional level.
Oh, really?
Seems like the coaches in college, the kids mix it up more. And I know HBU, Ron Cottrell over at HBU, I think I see more busted up mouths from his practices than anybody's because he's got kids diving for loose balls, and
Really?
they're really into it. So
I graduated from HBU in 2004.
Did you?
So, yep.
Well, it's the college athlete versus the professional athlete are just night and day as far as their attitudes and all. And I love the professional athletes. I'm not saying that professional athletes are bad, but the professional athletes have hit the higher echelon, and they know it. And sometimes I think that they're pacing themselves and saving their bodies because it's money to them as opposed to just wanting to make the team, wanting to start, wanting to get minutes in the game, that type of thing.
All right, so you said, repeat that again, the American Academy of Dentistry?
It's Academy of Sports Dentistry.
Academy of Sports Dentistry?
Right.
So that'd be the first place to look.
Right.
And then...
They have a website. You can go on the website, see who's in the Houston area, and go from there.
Okay. And then if, maybe if they can't come out to be ours, then maybe they can recommend somebody in our area or something like that.
Right.
So,
but like I said, if you don't have any luck there, just check with the local dentist in the area. A local dentist should jump at the chance to be a team dentist because it's a site, a potential for referrals.
Right.
And people say, "Oh, do you still take new patients?" Well, I'm 60 years old and I still take new patients. That's where you make an income because you get all the others fixed, so you need new ones.
I guess so.
So anybody that says they don't take new patients is either they're trying to wind down and not practice anymore, or they're not telling you the truth. Maybe they just wanted to be discriminatory against somebody or something.
Yeah. Okay. Did you have any other questions about dentists? I know we're trying to keep it short and you get back to work or something.
Well, I appreciate the opportunity to talk to you. As far as dentistry goes, there's still a lot of areas I get frustrated with that we have not made advances like I feel like we should have as a profession, but we have made tremendous advances over even the last 10 years. And dentistry, as a result, is becoming more fun again because I'm getting new procedures that I'm constantly getting updated on, new equipment, that type of thing. And it's made dentistry fun again for me as a dentist. But the important thing is for these young guys coming out that they never feel like they're there. They feel like they always got to learn. When you quit learning, something's wrong because they're always coming out with new things. We haven't had a lot of advances in the, like I said in the lecture, in the on the field, in the locker room protocols. But most of the stuff, you guys' hands are tied by the State Board of Dental Examiners because they will only allow dentists to do it, such as take an impression for a mouthpiece. Now, I know guys who do, and I wouldn't turn them in or anything, but if they get caught, it's a very serious matter with the State Board of Dental Examiners, and they'll come at you, whether you be a lay person. They don't just govern the dentist. They can actually have charges filed against a person for practicing without a license and that type of thing. So you don't want to get caught in that situation. So now, as the rule reads, the dentist does not physically necessarily have to be on site. He has to be very quickly available in case there's an emergency, because something as simple as taking an impression sounds very simple on the surface, but if they swallowed some impression material and choked, what would you do? Would you know how to basically CPR goes into play there, but the type of thing is you don't want to get them in that situation. You don't want to. There's a certain way to load an impression tray when you're taking an impression. If you overload it, half of it goes down their throat, and that's when they choke. So just little things like that. But you want to have a team dentist available, and a referral source. They should jump at it, especially a young guy. And the young guys, even though they haven't been around and learned through the School of Knox, they might have had some different training in school because they just came out. I graduated from school, 35 years ago, Well, these young guys who graduated 5 years ago, hopefully they're teaching them newer techniques
Right.
than they taught me, and that I had to go out and learn on my own. You know. Okay.
All right. Well, that's Dr. O'Brien, the team physician or team dentist for pretty much everybody who's famous in Houston.
I've been blessed. I've been blessed. You know, that getting the job is, you know, you have to have a stroke of luck to get the job. Keeping the job is hard work. And that's what people say, well, how'd you become the team dentist? Well, the Rockets, you know, I won't bore you with it, but I basically, someone referred one of the players' wives to me. She came to me. I did some cosmetic work. She liked it. She sent her husband in. He sent other players. Next thing you know, I'm a team dentist. Well, that's where it all started. And then from there, that was in 1984. And so we've had a complete changeover of medical staffs, what, 2 times or 3 times at the Rockets? 3 times. Walt, he had Baker leave, Walt come, Walt leave, Texas Orthopedics come, then Walt's back. Yeah, that's right. So, but they kept me. See, I'm independent from them, and I was blessed, and the trainers liked me, and they kept me. So you have to be available, and that's what some guys might not like. Is, I mean, many a time I've had to go into the office, you know, to meet somebody from a sporting event or something when I'd rather be at home, you know, with my wife or or whatever, or have to leave a game and go back to the office with a player. I mean, with the Rockets, I've had that happen numerous times. I have to go back to the office with players and get out there at 1 in the morning and go back and see patients the next morning at, you know, 8 o'clock. But keeping the job is you got to be doing something right to keep the job. And the Texans, I've been with them since they started. Dynamo, I've been with them for about, I don't know, probably the second year they were here. And U of H, I've been with them about 5 years now. I've been with HBU since 90. When did they start basketball back again? You were there, weren't you, when I started with them?
Well, I was back in '82.
Oh, no, it wasn't then. It was must have been like around 9. We had that VCI league there,
That's right.
and that's where I met Ron. And we struck up a relationship. Okay.
All right. Well, thank you, Dr. Bryan.
Thank you very much for your time.
Got to be out plenty of time, Doc.
Actually, my appointment is I'm heading.